Assalamu alaikum. I'm Dr. Maham Khalid, the co-director of the academic wing of Ventilators for Pakistan, and I welcome you all to the third session of our COVEB series and the last session of medicine. For all new attendees, I would like to mention that this is part of the educational activities taken up by Ventilators for Pakistan. As the name suggests, this project was started by our founders, Dr. Sabah A.K. Akhtar and Dr. Rabil Tariq, in order to donate ventilators across various government hospitals in Pakistan and to eventually better the critical care across the country. We have donated 8 ventilators to date. The first ventilator was donated to Holy Family Hospital, Rawalpindi. The second ventilator was donated to Ayub Medical Hospital, Aptabad. The third to Sedu Teaching Hospital, Sawat. The fourth to Civil Hospital, Karachi. The fifth to GGH Ghulam Muhammadabad, Faisalabad. The sixth to PIMS, Islamabad. The seventh to Ghulam Devi Chest Hospital, Lahore. And our recent donation of the 8th vent was to DHQ Teaching Hospital, Khuzdar, Balochistan. The team that has largely made this a reality is the procurement team at VFP, and it is being headed by Dr. Anila Sikandar and Dr. Fahad Akhtar. The members include Dr. Qadar Zafar, Dr. Ali Mohsin Chaudhry, Dr. Danial Hashmi, Muhammad Umar Riaz Gondar, Dr. Pinar Farooq, and Mr. Saad Sikandar. They not only procure the ventilators from the vendors, but also inspect hospitals to select the ones that fit the criteria set by VFP. Despite the fear of COVID, they have been going to hospitals with donations and did and will continue to brave the pandemic to serve our nation. We thank them for their unrelenting efforts and wish them best of luck for the future endeavors. Over the weeks, we will try to share all the efforts that VFP has been making to combat this deadly disease. Now, without further ado, I would like to introduce my co-director and my co-host for the evening, Dr. Mavish Redkin.
Thank you so much, Dr. Maham. Assalamu alaikum. It is an honor to co-host the COVEB educational series. I'm the co-director of the academic wing for VFP and also the co-founder for Yardim Foundation, which was founded about a year ago by my sister and I. And the sole intention was to help our nation in whatever way we can. We currently have 3 running programs. Number 1 is Yardim Dental Program. Our second is Mental Health Awareness Campaign and FRP. FRP is a food and ration program which we started during the pandemic and have so far helped 800 plus families during the lockdown. Due to the overwhelming support we received, we started a long-term program to provide monthly ration to families with no means of support, such as widows, divorcees, orphans, handicapped, and disabled persons. In this program, sponsors can choose to provide funds to cater to a family for a specific time period, a month, 3 months, 6 months, even up to a year. Our wonderful members purchase pack and deliver the ration packs personally. I would also like to take this opportunity to thank Rawalpindi Medical University, which has accredited these education series for all of you to enjoy. Thank you to the Vice Chancellor and the medical education team of RMU. Over to you, Dr. Maham.
I would also like to thank the personalities without whose patronage we would not be able to hold this series. Our patron-in-chief for these series is Professor Emeritus Lieutenant General Mahmood Ahmed Akhtar, recipient of Hilal-e-Imtiaz Military, and our patron is Professor Dr. Samina Naeemullah, who is a recipient of President of Pakistan Gold Medal by the Pakistan Pediatric Association. Thank you for your support. Now, I would like to welcome our first speaker of tonight, Dr. Samina Fazal, who is a graduate of Fatma Jinnah Medical College, Lahore. She is a clinical nephrologist and has over 32 years of experience in the field of medicine. She is currently working at Baylor University Medical Center, Baylor Scott and White Health Services at Dallas, Texas. It's an honor to have you as a speaker tonight, ma'am. Over to you.
Okay. All right. So, hi, everyone. I'm going to talk about kidneys and COVID today. And we're talking mostly about management of acute kidney injury and COVID, and I will touch upon mostly management as well as management of dialysis patients and transplant patients during this talk. So let me start to... Okay, I'm trying to get my screen on here. I thought it was already there. Okay. Oops, I need a... Okay, we'll start with this. So, starting on... I can't share my screen.
Ma'am, we can see your
My
screen.
screen is jammed, I think.
We can see your screen. You only need to run the slideshow.
Yeah, I know. So wait a second. I think my screen is jammed for some reason. My slideshow is not working, but I will try. Okay. Okay. Let's see. I think my slideshow is jammed for some reason.
We can play it for you, ma'am, if you want.
Can you have control of my slideshow? I mean, I cannot move this. Okay.
Yes, just give me a moment.
Okay. For some reason, it's jammed.
No worries, ma'am. We'll fix it right away. Thank you so much, Dr. Samina, for being here with us. It's an honor for you to present.
I know, but I have to move this slideshow. Start sharing. Can I start all over again if I start? I can't even see my slideshow anymore.
Yes, we're just fixing this, ma'am. How's the weather in Dallas?
It's warm.
It's warm.
Okay, hold on. I can. Okay, so we'll start talking about the kidney, and I will bring up the slideshow. So let me start talking about prevalence of kidney disease in COVID. Now, infections in COVID, as we already all know, are primarily respiratory. It's a respiratory illness, and most patients will develop mild symptoms, but 5% will progress to severe disease and require hospitalizations. Now, patients with severe symptoms will usually present with severe acute respiratory distress syndrome, septic shock, and multi-organ failure. Kidney involvement is very frequent in COVID-19. About more than 40% of cases at presentation will present with abnormal proteinuria. Now, acute kidney injury also is very common in critically ill patients, mostly in the ICU, and it affects about 20 to 40% of patients.
Ma'am, whenever you would like us to move to the next slide, you can tell us. We are sharing
Yes,
it.
next.
Thank you.
So kidney injury in patients with acute COVID infections is considered a marker of disease severity and a very negative prognostic factor. Obviously, the survival is impeded with acute kidney injury. One of the issues is that the burden of disease that is already present in kidney patients may not be obvious at the time of presentation. A lot of times their creatinines or kidney functions may be overestimated, and we may not have the right idea at the time of presentation. 20% of patients with AKI in a COVID setting will require renal replacement therapy. Now, the job of a nephrologist is to recognize the acute kidney injury early and come up with therapeutic maneuvers to prevent and limit further progression of the disease, and that would affect the morbidity and mortality. Next. Now, what I'm going to talk about today is the pathophysiology and the mechanism of AKI in COVID-19. I will talk about the recommendations of clinical practice guidelines. I will also talk about prevention and management of AKI. I will talk about indication of the use of renal replacement therapy and sequential extracorporeal therapies. Now, I do understand that, we don't have availability of extracorporeal therapy in Pakistan. I think maybe just a couple of hospitals might have it, and I could be wrong. But mostly the ones that we are using here is ECMO, and the sequential corporeal therapies are being used for research. So, and I will talk about them going forward. Next. So talking about the pathophysiology of acute kidney injury in COVID-19, we will start with our bread and butter kidney failure or acute kidney injury, which happens even in non-COVID situations. And the multifactorial predisposing factors are sepsis, hypotension, hypovolemia, nephrotoxin-induced injury, cardiorenal compromise with both the left and the right heart failure. So that's our run-of-the-mill kidney issues. Now, pertinent to, can you go back? Yes, pertinent to COVID-19, I think the novel things about this is that the SARS virus itself will cause direct endothelial injury to the renal tubular epithelium. So as we know that once you get infected by the SARS virus, it will directly infect or attack the endothelium of the lungs and other organs, including the kidney. And it will start up a cytokine storm, or it will immunomodulate. The immunomodulatory system is revved up, resulting in production of cytokines and chemokines. Now, the cytokines and chemokines are chemical messengers that, do a lot of stuff in our body. But in this case, they form in a storm-like shape and attack the endothelium. So these are compromised of both pro-inflammatory and anti-inflammatory agents. Now, so clearly the pro-inflammatory agents are overwhelming, including IL-6, IL-2, TNF-alpha, interleukin beta 1. So these are the overwhelming pro-inflammatory cytokines that we see, as opposed to, I guess, IL-10, which is anti-inflammatory. So once you have this storm resulting in endothelial damage and renal tubular damage. Now, the SARS-CoV-2 virus will attack the renal tubular epithelium and multiple other epitheliums through an ACE2 receptor. Now, the ACE2 receptor is present on multiple organs, mostly located in the heart, but a lot of it is also located in the kidneys. So the SARS-CoV-2 virus will attach itself to the ACE2 receptor, and via a transmembrane protein will enter the cell and begin to replicate inside the cell. Next. Now, once it's inside the cell and it's replicating, it will affect the mitochondria and cause paralysis of the mitochondria. It will directly attack the acute, the renal epithelium or the tubular epithelium and cause acute tubular necrosis with loss of brush border and loss of basolateral membrane, sloughing of the membrane, and also with reabsorbed paraprotein vacuoles that enter the cell once it swells and starts absorbing everything outside. It will also affect the glomeruli, and the pattern that we are seeing in the limited amounts of biopsies that we have available, we have seen a lot of collapsing glomerulopathy, which leads to FSGS with a bad prognosis. And along with the tubular epithelium, the virus, it also attaches itself to the podocytes. And once you, and the podocytes get effaced, and once you get effacement, obviously you will get a bunch of protein leakage. So it's a whole, in the biopsies that we've seen, especially in the immunofluorescence studies, we haven't seen much immune deposits, but we do see a lot of podocyte effacement. Next. Now, again, so we've already talked about the SARS-CoV-2 related immune dysregulation that I just talked about. And, it manifests as lymphopenia and cytokine release storm. So I've already talked about that. Next. Other factors that are also other disease processes that you see in acute kidney injury are acute rhabdomyolysis. You also have the macrophage activation system, which does a lot of damage, mostly in the mesangium. And then, as we all know, that COVID presents with a very singular hypercoagulable state, and that results in a microemboli and a microthrombi being formed in the small vessels of the kidneys, and also cause endotheliitis. Now, it presents like a TMA kind of a picture, even though we've not been treating TMA in the routine way that we do, but we are seeing a lot of microemboli and microthrombi. Next. All right, so now I'm going to kind of bring this all together for you guys in this diagram. I'm going to talk about all these organs and how they crosstalk with the kidney during this SARS-CoV-2 infection. So starting with the initial presentation, when your patients present to you, a lot of times they have been febrile for several days. And there's a lot of psychological burden of the disease. And there is also decreased PO intake, a lot of fear. Patients are not drinking fluids. So they usually present in a hypovolemic setting. And a lot of times when they present with shortness of breath, ER physicians are reluctant to give them fluids just because they feel that, their volume is up and they do not wish to give them fluids. So they will present with a hypovolemic setting. And if you have underlying endothelial attack ongoing with the kidneys, combined it with the hypovolemia, resulting in acute kidney injury or hyperperfusion injury. The other aspect is obviously the interleukin storm that we talked about already, and that causes direct endothelial dysfunction that I talked about. Now, moving on to the pneumonia part of the disease. Now, we all know that patients develop ARDS and are mostly vented, so they undergo mechanical ventilation or they are placed on ECMO. Now, the mechanical ventilation aspect of this disease pertaining to kidney is actually, if I could say, two-faced. You could have a lot of research that has been done has shown that at the time of intubation, at the time of mechanical ventilation, patients are developing acute kidney injury. And at the same time, we've also seen that, and I'll touch on that study a little bit later on, which was a single center study, and it was actually a retrospective study, but the important thing was that there were a number of patients. The N was really large. It showed that most patients that are vented will have AKI. It's almost 60% of vented patients as opposed to non-vented patients. So the ventilation aspect is actually two-phased in a way that we've also noticed that patients that are vented, in fact, do well with acute kidney injury because at the time of intubating the patients, you also take care of the hemodynamic changes that affects the kidneys. So the lung protection actually helps with the kidneys, with the kidney protection. So it's actually kind of an oxymoron or a double face thing to understand. Okay, can I go back to my slides? I can't see my slides.
Yes, ma'am.
Okay, I can't see my slides. Anyway, so the other thing to talk about is also now looking at the heart. Now, as we remember, the ACE receptors are found in very large amounts in the myocardium, and the heart usually gets affected with a huge amount of myocarditis, which results in the right heart failure and the left heart failure. So as far as the right heart failure is concerned, that will result in volume overload and decreased venous return for the medical students that are here. and will result in hepatic congestion and renal congestion or renal vascular congestion, resulting in acute kidney injury. On the flip side, if you look at the left heart, the severe myocarditis that we see on the left heart will result in arterial hyperperfusion, arterial underfilling, resulting in acute kidney injury. So moving on, can I have the next slide, please?
Yes, ma'am. We're just putting
Okay. Okay, that's fine. So yes. So can I have the next slide now? Wait a second. I think I've talked about all of this. Yes. So this diagram, in fact, actually for the medical students that may be in the audience, is really important to understand the crosstalk between organs during COVID-2 storm as to how they interact with each other. Can we go to the next slide, please? Yes. So this is the study that I talked about in ventilated patients. This was recently published in KI, or Kidney International, and it was done at one of the New York hospitals, Hirsch et al. And this actually showed that the timing of AKI was in close temporal proximity to the time of mechanical ventilation and intubation. And the rate of AKI in the vented patients was about close to 90%, as opposed to non-vented patients, which was 21.7%. And again, if we look at the stage 3 kidney AKI, that usually was found in 65% of vented patients as compared to 6.5% of non-vented patients. Now, you can make the case easily that patients who are vented are way more sicker and therefore develop acute kidney injury. Obviously, that case could be made. And also note that all patients that required renal replacement therapy were vented. Okay, next. So how do we manage acute kidney injury in COVID? Now, the whole COVID situation, we don't have therapeutic measures in place at this point. It's too novel. It's too new. We do have trials going on with remdesivir and IL-6 inhibitors, TOSI and SARI, but most of the management is supportive. For a nephrologist on the case who is dealing with AKI, one of our most, our bane of existence is the fluid management. And also, based on the fluid management, avoidance of volute trauma and barotrauma, which I'll talk about, and the usual things such as monitoring creatinine, electrolytes, and urine output. And also, hemodynamic monitoring is very important for us to maintain kidney health. Next. Now, as far as the volume management is concerned, initial assessment is important. Then we talk about initial fluid resuscitation. Again, like I talked about, a lot of ER physicians are reluctant to give fluids to these patients, but luckily we know that there are sepsis protocol in place, which usually amount to 35 ml per kg of fluids given to the patients who present in with a septic or sepsis-like picture. And usually the recommended are crystalloids. It's too early to give them colloids, so we stick to crystalloids. Again, once you have the initial resuscitation, our guidelines are that, the patients should be switched to maintenance fluids to avoid hypervolemia. The other things that we assess on an ongoing basis once the patients are transferred to the floor or to the ICU is the balance between fluid responsiveness and fluid tolerance. And usually this is obviously an ongoing process. The idea for the nephrologist is to restore normal volume as much as possible to avoid overload, the risk of pulmonary edema, right ventricular overload, and congestion and subsequent AKI, like I already talked about. The other side of it is hyperperfusion. So you try to avoid intravascular volume depletion that could result in ischemic nephropathy. Next. So as far as the volume management is concerned, if you break it down, obviously history, always irreplaceable. Like my mentor always tells me, when nothing works out, go see the patient, go talk to the patient. So again, like I said, fever. Now I'm just going to throw in the NSAIDs over here because there's been a lot of talk about NSAIDs. And suffice it to say, NSAIDs are the sworn enemies of nephrologists. So a lot of ibuprofen and NSAIDs are being used by patients who get febrile, and by the time they come to us, they're almost in a nephrotoxic state. So that's something that I'm going to throw in here with the volume. Clinical exam is obviously irreplaceable. We are having a lot of issues with maintaining our clinical exam skills with COVID patients, given the nature of the disease. Also for, with the availability of PPE, and we are not getting access to our patients as much as we would like to. So the clinical exam has literally become a team effort, with the nurses being involved, with your ICU team or your hospitalist, as well as the nephrologist. So that's something that, we kind of do on a community basis now, given the nature of the disease. In the ICU setting, CVP and mean arterial pressures are something to monitor for your volume status. As far as, obviously in the ICU setting, on the floor setting or in the ward setting, blood pressure monitoring is obviously, in correlation with clinical exam is important. One of the tools that I find very useful is a bedside echo to look at the inferior vena cava and to look at its collapsibility. That will give you an idea of your intravascular volume status. One of the things that I use, which is something, probably very ancient now, is serum uric acid. And I would encourage, the younger doctors and the medical students to kind of pay attention to that. That is something I find very useful to establish intravascular volume status, which kind of gives you an idea of what the volume is. Obviously, a high uric acid, barring other states such as gout and all that, will generally give you an idea that the patient is intravascularly depleted, and a low uric acid in the 2 or 3 range will give you, an idea that there's a lot of free water. Urine lights are invaluable, looking at the urine sodium, urine chloride. And then obviously something that we have in our arsenal is diuretics. Now, I would like to bring up the furosemide stress test. I mean, I know I'm talking about the COVID situation, but even in a non-COVID situation, I think that's something that is not used very frequently. And it's actually a very simple and a relatively cheap test that you can do to assess the volume status of the patient, and also to predict the evolution of acute kidney injury going forward. So the furosemide stress test, or the LASIX, or whatever you call it, it's 1 milligram to 1.5 milligrams per kg is used, and you monitor the urine output over the next 2 hours. And if you are unable to get a urine output of 200 ml, that would indicate that going forwards, your diuretics may not be that effective, and that would indicate that other measures would need to be used. So this is something that I would strongly encourage people to use, even in a non-COVID situation. The furosemide stress test will really give you a good idea about the progression of kidney disease in your AKI patients. Next. So talking about the barotrauma and the volutrauma look like, fancy words, but basically, again, this is hypervolemia pertaining to the kidneys, and barotrauma is related to the lungs. Now, we've seen that if we apply lung protective ventilation, and I touched upon this earlier, if we use lung protective ventilation or ventilate patients in a timely fashion, we do reduce the risk of new or worsening AKI by attenuating the hemodynamic effects and the cytokine burdens on the kidneys. Now, for the younger people out here, we're still looking for novel tubular damage biomarkers. That is something that we would love to find to predict and manage AKI in a COVID situation. So far, we don't have many. Next. Okay, so let me talk about hypovolemia. I think I touched upon it more, but a point that I would like to make is obviously it should be avoided, and use all the tools that are at your disposal to avoid hypovolemia. But also remember that patients with COVID require high positive end expiratory pressure strategies and recruitment measures. So you're using high PEEP for these patients to recruit their alveoli in ARDS. And once you do that, remember, you do compromise the cardiac output. You decrease the venous return, you decrease cardiac output. And if your patient is hypovolemic, remember that you will cause worsening of the reduction of the cardiac output, and you will cause severe reduction in the peripheral perfusion, not only for the kidneys, but for the rest of the body. So it is very important that you alleviate hypovolemia in these cases so you can help your pulmonary colleagues, apply a high PEEP and recruitment measures for these patients. Next. Other things to manage from a nephrology point of view in these patients is acid-base status, of course. Obviously, you check the medication list every day and make sure that they're not getting anything that is nephrotoxic. And the antibiotics that are being used, please make sure that you adjust the dose to their creatinine clearance. And obviously, a lot of times, your pulmonary colleagues would want to do CAT scans. So your job is to advocate avoidance of IV contrast dyes. Next. Now, once we've done all the medical management and we've tried our best, but our patients are, the renal function is still not getting better, obviously the next step is renal replacement therapy. So what are the indications of you choosing to put your patients on renal replacement therapies? Obviously, oliguria, refractory hypervolemia. Patients are getting a lot of blood products. They're getting a lot of FFPs. They're getting, IV heparin. So it's important that, you find a way to reduce the hypervolemia. And obviously with the hypervolemia, your respiratory status is getting worse. So that's where you come in. Again, refractory severe hyperkalemia. This is usually the usual indication, but I have used renal replacement therapy even with severe hyponatremia in these cases. And usually hyponatremia you will see would to reflect hypervolemia. Of course, acidosis, severe metabolic acidosis with all the catabolic events going on in the body, and azotemia. Now, ideally, in an ideal world, and again, I would address the medical students and the younger ones over here looking at the future. One of the ideal considerations that we want to use is to use these extracorporeal organ therapies for removal of cytokines in setting of cytokine release storms, even in the absence of AKI. So I mean, what you're using the pattern of renal replacement therapy where you remove substances from the body and extrapolate it for extracorporeal therapies to remove cytokines. So if you're able to do that, you should be able to abate COVID. So that's something that's futuristic that we want to think about. Next. Now, the modalities that we choose for renal replacement therapy in these cases, the first one, obviously, the ideal and the modality of choice is continuous renal replacement therapy, or CRRT, or CVVHD, or CVVHDF, or CAVH. So you have all these continuous renal replacement therapies that are ideal given the hemodynamic instability of these patients. However, you can use intermittent hemodialysis also. I have become, kind of a big proponent of intermittent hemodialysis in these patients, only when you don't have large volumes that need to be removed. So if you want to do clearance in these patients and address their acidosis or their hyperkalemia or their azotemia, intermittent hemodialysis or regular dialysis machines can be used, provided you do not have to remove volume. Now, the other options are the low flow machines, which personally I have not used since my fellowship, is the SLEDD technique, which are slow flow machines in which you use a regular hemodialysis machines and you dial a low blood flow, and they can be used for 8-hour to 6 to 8 hour periods. Now, with the renal replacement therapy, you open up a whole Pandora box of multiple logistical issues and nursing issues that need to be tackled. So I'm just going to touch on them, but I don't think this is the scope of this talk. Next, please. You know what? Can we move on to the next one and we'll come back to this, please? Yes. So talking about the modality of renal replacement therapy, a lot of logistical issues with the current pandemic, just because the number of patients is so high that we have ended up using or sharing these machines. So, so first of all, availability of filters, supplies, certified skilled nurses who will do the CRRT on a round-the-clock basis. And then, again, like I said, we are sharing these machines. So we are doing something called shift therapies, where you use a machine 12 hours for one patient and 12 hours for another patient. And what usually happens is that the patient will generally have to go for a CAT scan, have to go for a procedure, and you know, that can be done in the non-CRRT time. So we are using machines on a 12 hours basis, which means that two patients are sharing a machine, and it becomes really relevant with the amount or the burden of people fighting this disease. The other thing to establish is obviously a vascular access that we place. I usually use a 12.5 French, and my site is the right jugular vein because of the visibility, and obviously the infection issue is there. If you put a femoral catheter, infection issues are way higher than the jugular. But the other thing to be very careful about these patients is that, remember, these patients are prone on a regular basis. So you don't want to put a catheter in their femoral vein and prone them and have the catheter pulled out, because in that case, patients who bleed in their femoral veins will bleed to no end without you even finding out, because they bleed in their thighs. So as far as the jugulars are concerned, the visibility is a big issue. You're able to see it. You are also able to assess the anchorage of the catheter during proning. So these are the logistical issues that are important with the modality. Next. Again, the prescription to be delivered with renal replacement therapy, we try to give 35 milligrams per ml per hour of dialysis to these patients. We end up delivering only 25 milligrams per ml. Of course, the blood and the dialysate flows have to be adjusted with the hemodynamic situation of the patient. If the blood pressures are too low, you might end up dropping blood flows a little bit. Again, the ultrafiltration, which is the key role in this modality, is removal of volume. You have to play with that given the hemodynamic stability. And usually I would work with the pressors. I do increase the pressors if I feel that I'm able to remove more fluid. So within safety range, I will go up on the pressors. The other things to manage are electrolytes. A lot of electrolytes are removed by these continuous therapies, and they need to be monitored on a daily basis and replaced. Anticoagulation is a big thing, especially with the hypercoagulable situation in these patients. So low molecular weight heparin, pre-filter IV heparin. We also use regional anticoagulation such as citrate, and you basically manage it with monitoring ionized calcium. This could be a board question for you guys. So anticoagulation and also IV heparin in these patients and factor Xa inhibitors all are being used across the board, and especially once your patient is and your AKI patient is receiving renal replacement therapy in the ICU, anticoagulation becomes very relevant for good performance of the therapy. Next. Can we go back to the slide that I missed earlier? I want to talk about that first. This one, yes. So again, this is for the younger people in the audience. This is actually kind of a fantasy. It's kind of a fantasy idealistic approach, but this is something again looking at the future. And I hope that some of you would be doing this. I'd like to talk about obviously the need to establish novel tubular damage biomarkers in the prediction and management of acute kidney injury in coronavirus. It seems that coronavirus is going to stay with us. So that's something that would need us to potentially guide management in these patients. Including fluid management, ventilation strategy, recruitment maneuvers that we just talked about. The other thing that I already talked about is the sequential extracorporeal therapies. And in this, you can use the basis of renal replacement therapy to remove cytokines and chemokines and help to provide organ support and decrease the progression of COVID severity. And then one of the things that I'm really excited about is and the trials are going on for this, is the ability to use the low flow extracorporeal therapies to remove carbon dioxide using RRT platforms, using renal replacement therapy platforms to remove carbon dioxide in hypercapnic patients. As you know that with ARDS, one of our issues is retention of CO2. So that is something that is very exciting for me, that we can use heme absorption filters and low flow extracorporeal therapies to remove carbon dioxide so we can oxygenate these patients better. And of course, we are pioneers as far as the renal replacement is concerned. And if other specialties will work on this and do this, that would be pretty amazing. And again, this can also be used in bacterial sepsis in non-COVID patients. So we can use these heme adsorption therapies to remove sequelae of bacterial sepsis, like endotoxins, immune modulation, chemokines. We can remove this and improve, our septic patients. So I think that's something to look for in the future. Can we go back to the last slide, please? The diagram. This one, yes. So I'm sorry, I'm missing the headline over here, but I would like to touch upon diabetes just because, it's usually bread and butter of nephrologists. And, we see about 35% of our ESRD or end-stage kidney cases will stem from diabetes. So I would like to bring up diabetes in relation to COVID, given the fact that, there is a lot of mortality associated with diabetes and with hypertension. So before the talk, I did look at several articles trying to find out if there was some connection other than the usual that we know with diabetes, but so far none. So our predisposing factors for diabetic patients in COVID are the usual obesity, increased inflammation that's already present in diabetic patients, persistent hyperglycemia, older age, and of course comorbid conditions such as hypertension and cardiovascular diseases. Renal disease obviously is also part of diabetes. So, you start with patients who are already with established renal disease. That will predispose us to higher mortality in COVID in diabetic patients. I don't have any further slides, but I would like to bring up two more populations, and then I will end this. The two populations that I would like to bring up is the ESRD population, our dialysis patients, and COVID management in dialysis patients. We've seen a number of patients who have gotten infected with COVID. Their management is relatively less complex because they already have an established RRT modality from a nephrology point of view. So we already have an access, we already have an RRT modality. It is very unusual for us to use CRRT or continuous therapy for those patients. The last population I would like to touch upon is our transplant patients. So literally, transplant patients are our AKI patients on steroids. Not literally steroids, but I mean it in a kind of a literal sense or a non-literal sense, that their management becomes very complex given their already immune suppressed status and their immune suppressed medications. So that's something that's a whole different ball game. And I will end my talk over there. And if there are any questions, I would be happy to answer.
Thank you so much, Dr. Samina. That was a wonderful presentation. We do have a couple of questions. If you're okay with it, I'll start. Okay. So the first question is, can COVID present solely with urinary or renal symptoms without other symptoms? And if it does, how will we distinguish it from other causes of renal
Usually, as we know, renal disease is typically asymptomatic. Per se, you always have to get that renal profile to see that there is kidney involvement. However, the hypovolemia, the patient can tell you my urine output has decreased. I haven't been peeing for several days. So that kind of is an indication. So, we're seeing a lot of presentations with strokes. We're seeing with hypercoagulable issues. So per se, you don't see a presentation with renal catastrophe, but you will see some degree of AKI. Again, a lot of factors are if the patient already has some degree of CKD. So that is something that plays in. But if the question is that it presents with a renal catastrophe, no, not really. But yes, a little bit here and a little bit there, like oliguria and urea. And then, of course, we can pick up on AKI. But usually you see a whole spectrum with fever, decreased intake, and that's the usual presentation.
But not just solitary renal symptoms. Right?
Not just solitary. Again, renal symptoms are not, like I said, renal disease, it's notorious for not having symptoms. It's a silent disease. Yes, I mean, there's a flurry of symptoms surrounding it, but not actual renal catastrophe. But having said that, proteinuria will be discovered in these patients again early.
So the next question, thank you, ma'am. The next question is, are people with ongoing kidney disease or those who are on dialysis more prone to COVID-related kidney disease?
After taking care of several, I take care of about 100 dialysis patients on my shifts. It's the usual susceptibility from an exposure standpoint, which brings us in from the safety perspective, where patients are exposed to COVID. As far as them being more susceptible, I'm not sure that they are more susceptible. If they practice safety precautions just as we do with other patients, they are not susceptible from that point of view. But yes, our initial, when COVID started, our initial thought process was that once our dialysis patients got infected, we would see catastrophic results. But, surprisingly, they have done okay. A lot of dialysis patients have done okay. We've had very little mortality in our established dialysis patients, and I'm not sure what I mean, unless they're used to disease processes, I'm not sure. But it has been a surprise that they have exhibited less complications as opposed to de novo AKI and de novo patients.
Thank you, ma'am. The next question is, how much heparin, what would be the dose of heparin dialysis which you would give in COVID patients?
Okay, so so what I like to do is, I'd like to give them off the bat, I'd like to give them 200 international units per hour. I would start with that. I start with the lower dose. A lot of times, a lot of people like to do pre-filter, but I just do simultaneous IV heparin. And I usually start with 200 international units.
Right, thank you.
And you can increase as needed.
Okay.
Balancing with, obviously, the risk of bleeding.
All right. So the last question is, what would be your preferred anticoagulant for a patient who developed HIT or has AKI as well?
Okay, so with HIT, we usually use agatrobans. Then we also use factor Xa inhibitors. That would usually be my preference. A lot of Xa inhibitors are in the market now, and we can use them. We can use them even orally.
And if the same patient with HIT had AKI, what would then be your preferred anticoagulant?
For agatroban, I usually use agatroban.
Right.
That's something that I prefer.
Okay. That concludes the question answer sessions for us. Okay. Actually, there is one more question. What precautions should a diabetic patient take to prevent COVID? And what are the safe glucose levels for that patient?
Okay, so again, universal precautions, which are safety precautions, is something that should be practiced. Nothing special as far as a diabetic patient is concerned. Obviously, your basic optimization of your diabetes. The usual levels that we suggest once they are admitted is anywhere, you would like to keep them around 140. 140 to 180 at times, but usually 140 milligrams is something that we would, per deciliter, is something that we would encourage. And that's usually in any ICU patients, that's the recommended glucose level or glycemia level.
Right. The next question is, how do we manage anticoagulation in patients requiring hemodialysis? I think some of it was answered before, but...
Right. So for hemodialysis patients, we generally, even in a non-COVID situation, they are usually getting heparin, 100 international units per kg, as a standard outpatient dialysis patients. So they're already on anticoagulation. And this is sub-Q heparin. I'm talking about sub-Q heparin and also, so we usually use about 5,000 units sub-Q twice a day in the hospital. However, with dialysis, like I said, 100 international units per kg with dialysis. So anywhere from 2,000 units to 4,000 to 5,000, 6,000. They usually get that with their regular dialysis. Some patients have issues with their accesses, and so we give them superimposed warfarin, maintaining their INR around 1.8, not too high. So we will usually use use warfarin for superimposed access issues. But standard baseline ESRD dialysis patients will get IV heparin with their treatment, with every treatment.
Right, thank you. The next question is, ma'am, if a patient has an MI, can we give him heparin
Sure.
And he also has CKD. So a patient
Sure.
with CKD who has an
Absolutely. Absolutely. There's no contraindication. There is
Right.
absolutely. Dialysis patients, in fact, and CKD patients, yes, absolutely. There is no contraindication at all.
All right. The next question, we have lots of questions. So the next question is, do you think that plasma therapy and immune modulating therapies help avoid kidney injury?
As far as plasma exchange is concerned, the plasma exchange and plaques is kind of falling out of favor. There was a recent study that came out, which is actually demeaning the use of plasma exchange in acute kidney injury. We're still using it in FSGS, in idiopathic FSGS, in Tasman patients, in recurrent FSGS, obviously in HUS, in hypertriglyceridemia. But as far as the immune modulation is concerned, the studies don't show a lot of benefit at this point with plasma exchange. So it's subjecting the patient to a significant procedure, but the studies have not shown benefit. And like I said, the most recent study, I think the PLEX study that came out, actually has really put down plasma exchange. And for immune modulation, honestly, I don't think we've even considered using it.
All right. Ma'am, the next question is, dexamethasone is being used increasingly now. How is that affecting the kidney, in your opinion?
Again, as far as the kidney is concerned, a lot of kidney diseases are treated with steroids. Steroids itself is a big issue. Steroid use itself is a big issue. As far as short-term steroid treatments are concerned, they are not affecting the kidneys as long as you're managing if you have simultaneous diabetes. But as far as directly affecting the kidneys, the short-term are not. They do not produce any kidney-specific adverse events. Again, they're short-term, so we're not adverse to using them. Yes, we are adverse to using long-term steroids, but dexamethasone is life-saving therapy in these cases. They are not. There's no kidney-specific adverse effect.
Right. Thank you so much, ma'am. This concludes our question-answer session. And we will now be moving on to our next speaker. Thank you so much, Dr. Samina, for giving us your valuable time. I had
Thank you.
Thank you.
Thank you.
Mavish, over to you.
Thank you so much, Dr. Maham. Our second speaker for tonight is Dr. Omar Rahman, who graduated from Army Medical College and did his internal medicine residency at Technical Care Fellowship at Mount Sinai, where he was awarded Fellow of the Year. As an associate program director for Critical Care Fellowship in Pennsylvania and is now faculty at Indiana University. He has won many teaching awards, has presented at international conferences, and has several publications with his name. He recently even had a COVID-related research published. He's leading 3 other research projects on COVID while working full-time in the COVID ICU. Please help me welcome Dr. Omar on stage.
Thank you very much. Can you hear me okay?
Yes, sir.
Okay, let me see if I can. Okay, and can you see my slideshow?
Yes, sir.
Okay. So thank you very much for inviting me to speak at this forum. It's an honor and a privilege. Especially thank you for the organizers from Ventilators for Pakistan and Yardim Foundation, and especially Dr. Sabah Akhtar. It's an amazing thing that you guys are doing here. Well, we'll talk about, and a little constrained with time. So my plan was to talk about the neurological manifestations of COVID-19 and then have a question answer session in the middle before going to the next presentation. But it may probably be better if I just do the back-to-back on presentations and then do the questions for both at the end. So as I was introduced, I am currently working in the COVID-19 unit. We have at Indiana University a 120-bed ICU tower, and of which we have dedicated about 40 odd beds to only COVID-19. And ever since the pandemic started, probably by late February, we had designated those areas as the COVID-19 unit. In the past, we had kind of reserved beds for the Ebola patients there, and that's why the nurses and the respiratory therapists were trained to manage those patients and follow the isolation and PPE techniques and stuff. So it's been a great experience working in the COVID ICU over the last few months. It is a vicious disease, and it is a real problem. And I'll share some of my experiences in the next presentation when we talk about critical care issues in COVID. But let's start with the neurological manifestations of COVID, which are not limited to stroke, which is the original title of the presentation. So just as a brief overview, there are about 6 million worldwide cases in about 200 countries and regions around the world of COVID-19. And as of today, I think there's more than 600,000 deaths. With COVID, the numbers change rapidly by the day, by the hour. So the main manifestation is pulmonary, and that's why it manifests as a severe acute respiratory syndrome, or SARS, the original name of this coronavirus species that caused the syndrome in 2003, and this is the mutated version causing the SARS-CoV-2 syndrome. The extra pulmonary manifestations, Dr. Fazal gave a great talk on kidneys, so I'm going to try to avoid talking about the kidneys in my next talk also. But the extrapulmonary manifestations are mainly because of two pathways, the hypercoagulation pathway and the hyperinflammatory pathway. These two problems are responsible for all of the systemic symptoms, including the central nervous system and peripheral nervous system disorders that we'll touch on. So as far as the incidence of neurological issues with COVID-19, we have very limited data. It is only limited to case series and case reports at this time. There is a new crisis going on. It's a new pandemic, and reports come out, trials come out every day, every week, and we keep gathering the information. So what I'm going to do is summarize what we have so far. So most of the case series describe clinical, radiological, and pathological data from COVID-19 patients. Pathological include autopsy and biopsy specimens. We have case reports of some unusual conditions that we'll touch on. And then there are incidental findings of neurological problems going in large descriptive series, which is very important as we'll go on through this presentation. There's also a lot of extrapolation we can derive from the other coronavirus epidemics, like the SARS and the Middle Eastern Respiratory Syndrome virus, the seasonal coronavirus infections, which were prevalent even before the novel viruses like the OC43 and HQ21 and whatnot, and the influenza experience where the viral pneumonias leading to neurological problems was well described. So let's look at the estimated projection of central nervous system, peripheral nervous system cases at this time. So we are basing this on our SARS-1, which is 2003, and the MERS case count. And if we even look at the same percentages, and obviously the number is going to be somewhere in the middle. The MERS syndrome was far more lethal, about 30% case fatality rate. And the SARS-1 was a little more benign compared to the SARS-CoV-2 currently. So the numbers are going to be somewhere in the middle. So if you look at the SARS case count, it was with people who have central nervous system disease was 0.04%. And out of those 8,000 cases, 3 were described as primary CNS problems with SARS. In the MERS crisis, it was described up to 20%. So same with peripheral nervous system problems. They're slightly more prevalent, 0.05% and about 16% in the MERS crisis. And the total number of CNS and PNS cases were 0.09% in the SARS and the 0.36% in the or 36% in the MERS case count. Now, if we take the same percentages and we extrapolate it to COVID-19, the problem becomes big because of the sheer number of patients. With the pandemic, with this data, which this slide was made in June, and you can see it is 4.8 million cases, which has obviously gone up now, more than 6 million cases. And based on that, if you use the same percentages from the SARS or the MERS, the numbers are going to be in the thousands at this time, and maybe tens of thousands or approaching hundreds of thousands by the time this pandemic slows down. So it's very important to be aware of all these neurological manifestations because we are definitely going to see them, and we are unfortunately seeing some of these cases. So the classification of neurological disorders is 2 broad classifications: the central nervous system and the peripheral nervous system. In the central nervous system, obviously cerebrovascular accident, which includes ischemic stroke and then intracerebral hemorrhage, followed by meningitis, encephalitis, and demyelination, acute demyelinating encephalomyelitis, which is basically white matter disease involving the brain or the spinal cord or both. CNS vasculitis because of vascular inflammation at the microscopic level, and then cranial nerve defects, which we've made a lot of news, you know, the loss of sense and of smell and taste. And then I'm going to talk about seizures and delirium separately, because these are these are manifestations of all these central nervous system disorders and can be due to other causes, and we need to be cognizant of that. As far as peripheral nervous system is concerned, the most common thing described in viral pneumonias or any sort of viral infection is a post-viral AIDP, or autoimmune inflammatory demyelinating polyneuropathy. Guillain-Barré syndrome is an example of that. Transverse myelitis due to viral infections. Autonomic dysfunction. There's increasing concern amongst providers caring in the ICU for COVID-19 that there may be some autonomic dysfunction. We have wild swings in hypotension and hypertension when we're taking care of critically ill patients. And then far more common is polyneuropathy and myopathy from either the viral infection itself causing some mild rhabdomyolysis, like Dr. Fazal mentioned in her last presentation, or the polyneuropathy or critical care-induced neuromuscular abnormalities, or CINMA, which is related to prolonged mechanical ventilation and critical illness. So the mechanisms of disease in the nervous system. So the exact mechanism by which SARS-CoV-2 penetrates the CNS has not been established yet. There are several hypotheses, and some really valid ones based on pathology and based on autopsy specimens. So the one is the hematogenous spread of SARS-CoV-2 from systemic circulation to cerebral circulation, where the slower flow in the brain is conducive to the virus damaging the capillary endothelium and gaining access to the brain tissue itself. The second is direct dissemination through the cribriform plate and olfactory bulb when a large viral load is inhaled through the nasopharyngeal tract. The third is endothelial cell invasion by the virus itself. As we know, there is endothelial damage from SARS-CoV-2, and the cerebral circulation endothelium is no exception. So monocytes and macrophages are activated. There's interaction of clotting and inflammatory cascades in the brain tissue. And finally, there's actually autopsy specimens from the SARS-1, MERS, and CoV-2 patients that show that there's neuronal death in the respiratory center medulla oblongata through an upregulation of interleukin-1 and interleukin-6 and other chemokines, probably through an inflammatory response or apoptosis. So the pathogenesis is related to the structure of the SARS-CoV virus itself. SARS-CoV virus has a spike protein surface unit 1 that has a high binding affinity to the ACE2 receptor. We know that, and the ACE2 receptor is spread everywhere, so in many tissue beds, including the heart, kidneys, brain, and blood vessels. The increased expression of ACE2 in the epithelial cells in the lower respiratory tract is what causes the main SARS syndrome, the epithelial cells by fusion with the cell membrane. ACE2 is, we now know, strongly expressed in the ventrolateral medulla and the nucleus of the tractus solitarius. And these are the two areas that are closely involved in the regulation of the respiratory cycle. The affinity of the virus for the olfactory bulb is likely to be a different mechanism because the ACE2 receptor is not prevalent there. In the rat model, transnasal exposure to SARS-CoV resulted in rapid detection of the virus in the piriform and infralimbic cortex, basal ganglia, and the midbrain. Once the virus was established in the brain, there was evidence of dissemination along the neurotransmitter pathways. It's either through the serotonergic dorsal raphe system or hematogenously through the Virchow-Robin spaces, which, as you remember from anatomy, are the perivascular spaces filled with interstitial fluid in the brain itself, around cerebral arterioles. So the neuronal dissemination model of coronavirus infection is in the peripheral nervous system, relies on the machinery of active transport, which requires proteins transporting the viruses across cell membranes, transport across the synaptic terminals, and then retrograde transport into the neuronal cell body from the blood vessel or the synapse back into the neuron axonal cell body itself. This transsynaptic transfer mechanism is actually been demonstrated in studies involving non-SARS-CoV-2 but other coronavirus strains such as the HEV67N coronavirus. So based on this pathophysiology and all this description of how the virus can affect the nervous system centrally or peripherally, we're going to talk about some broad categories. First, we'll talk about white matter disease, and then we'll talk about strokes and other instances. So there's the strong correlation between multiple sclerosis and coronavirus, not just SARS-CoV-2, but the other coronaviruses. In multiple sclerosis, there is toll-like receptors, the TLRs, which are responsible for host defense and recognition of invading pathogens. The same TLR4 receptors, which are listed from 1 through 12 and 13, the same subtypes of toll-like receptors are activated in multiple sclerosis, which are activated during coronavirus infections. These viral particles are also recognized by these same receptors, and they contribute to the modification of the immune response of the patient developing multiple sclerosis. So there is a potential link between viral infections and development of demyelinating diseases. In a pretty robust study of about 80 or 90 patients, there was the PCR for the 229E and OC43 coronavirus strains was prevalent in about 39-40 patients of multiple sclerosis. This was done a few years ago, and it indicated that coronavirus induced white matter disease is very similar in its pathophysiology to multiple sclerosis, where white matter plaques appear in different parts of the brain. There's also coronavirus-like particles in the perivascular cuffing of an MS plaque that have been demonstrated. In addition, there is when people measured antibodies to coronavirus 229E and 043 in a proportion of multiple sclerosis patients, these antibodies were present in the CSF. And that is the reason why there is the link of demyelination and the risk of acute disseminated encephalomyelitis in coronavirus. So according to the WHO, this is the current definition of acute disseminated encephalomyelitis associated with SARS-CoV-2, Guillain-Barré syndrome, and other acute neuropathies associated with SARS-CoV-2 infections. There is two categories, either a probable association or a possible association. The probable association is based on three criteria: that there is neurological disease onset within 6 weeks of acute infection with COVID-19. Number two, either SARS-CoV-2 RNA is detected in any sample or antibody evidence of acute SARS-CoV-2 infection is present. And then there is no evidence of other commonly associated causes of encephalomyelitis. A possible association is defined as neurological disease onset within 6 weeks of acute infection, same as before. That there is either SARS-CoV-2 RNA detected or antibodies detected, but there is evidence of other commonly associated causes. So it's a pretty self-explanatory definition. So as I described, white matter changes happening in this acute infection. There is myelin loss in the spinal cords of mice. This is actually with SARS-CoV-2, and they've discovered that there's, in the acute phase of the infection, there is myelin loss, and there's also myelin destruction demonstrated 2 to 3 weeks post-infection. So it can manifest later, and hence the definition allows for about 6 weeks from the acute infection. In the MERS-CoV-2 crisis, when the autopsies were done, it shows that there is periventricular deep white matter infection. There was white matter demyelination in corpus callosum, bilateral pons, midbrain, cerebellum. And in this particular autopsy sample, they found upper cervical spine cord lesions on the 24th day of the disease. This is an example of acute demyelinating encephalomyelitis from the current SARS-CoV-2 crisis of a case report from Great Britain. And you can see that this patient developed white matter changes initially, as you can see the MRI pictures, resulting in cerebral edema, which obviously increased. You can see different, the T2 weighted images as well as the flare, and ultimately developing what looks like a midline shift and brain herniation. And the patient died, and these are the autopsy specimens from the pathology specimens from the autopsy that show perivascular infiltration of lymphocytes and white matter changes with SARS-CoV-2. Now, in this particular patient, the CSF was also positive for the COVID-19 PCR. So now we'll shift to the actual meningitis encephalitis with COVID-19. I wanted to mention the encephalomyelitis part first because it's more devastating. Meningitis encephalitis, like all viral meningitis and encephalitis, may be self-limiting. But the WHO definition, again, let's go over that. SARS-CoV-2 meningitis, encephalitis, myelitis, or CNS vasculitis. They're all lumped together in the definition. For the confirmed, it is number one, SARS-CoV-2 is detected in the CSF or brain tissue, or evidence of SARS-CoV-2 specific intrathecal antibody. And number two, no other explanatory pathogen or cause is found. Now, this confirmed SARS-CoV-2 definition is only a few case reports in case series right now. What we're seeing mostly is this probable category, where there is SARS-CoV-2 detected in respiratory or other non-CNS samples, or evidence of SARS-CoV-2 specific antibody in serum indicating acute infection, and no other explanatory pathogen or cause found. For the possible category, the third category, which says that patients meet the definition of COVID-19 infection, but they have meningitis on top of it, but without detecting it in the CNS, or having the PCR positive, so to speak, but just having clinical signs and symptoms along with the picture of meningitis. So in meningitis and encephalitis, there's direct invasion of the neurons in the cerebrospinal fluid. There's microvascular inflammation. Hemorrhagic encephalitis has been reported. Again, autopsy samples show bilateral thalamic and medial temporal lobes and subinsular regions involved in the encephalitis in this one case report. Another CSF PCR positive patient showed lateral ventricle, the right temporal lobe, and hippocampus inflammation on autopsy. This is a case report, again, from a series in Great Britain, which shows bilateral thalamic area damage. Sorry, switch the slide. Yeah, and encephalitis on different cuts of the MRI. As far as stroke is concerned, which is a big concern, and there's some news reports about association of stroke and COVID-19. The definition, again, is probable or possible. Either SARS-CoV detected in CSF or other samples, or evidence of SARS-CoV-2 specific antibody in the serum indicating acute infection. And number two, no other traditional cardiovascular risk factors for stroke. And a possible association is when you have the COVID-19 detected in the CSF or acute antibodies against acute infection, but with traditional cardiovascular risk factors. This possible association definition is being met by a lot of patients in the COVID ICUs. So the pathogenesis is, again, there's like for any other stroke, there is either LVO or large vessel occlusion or small vessel disease. And in the large vessel occlusion, there is the traditional risk factors. There's atherosclerosis, there's emboli from the heart or the arch of the aorta, there's aortic thrombi and arrhythmias, which, among which atrial fibrillation is the most common. And then small vessel disease, which is the concern we have with COVID-19, is that there is potential for microvascular inflammation and a hypercoagulable pathway, which induces vasculitis, which in turn, in a patient who has risk factors of atherosclerosis, can cause microthrombosis of the smaller vessels in the brain. This microvascular thrombosis is mediated by endothelial dysfunction and thromboxane and axial inflammation. And the large vessel occlusion, which is defined as either the internal carotid, common carotid, or the first order branches of the middle cerebral artery, anterior cerebral artery, posterior cerebral artery, the vertebral arteries, basilar artery, are due to thrombosis or embolism. As you notice, the risk factors for traditional stroke, you will find them to be overlapping with a lot of the risk factors for developing severe COVID-19 infection. So thromboembolic states such as DVT and PE, patients who have limb thrombosis due to arterial occlusion in the extremities with COVID-19, which we'll talk about in our next talk. D-dimer levels, as we know now, the D-dimer levels correspond to the severity of illness in COVID-19 as well as the risk for thrombosis. And then traditional risk factors, diabetes, hypertension, CHF, hyperlipidemia, atrial fibrillation, having a high BMI, having a patent foramen ovale, and a prior history of stroke. All these are risk factors for developing severe COVID-19 infection, and they are obviously risk factors for stroke. An example of a patient who had a large, so this is a CT scan that shows bilateral ground glass opacities from SARS-CoV-2 infection. This is the CT angio that shows bilateral pulmonary emboli, very large ones. And the same patient, unfortunately, had a PFO and has evidence of not only small micro emboli, but also a large vessel occlusion in the MCA distribution, middle cerebral artery distribution, causing a large hemispheric stroke. Let's switch to the peripheral nervous system. Again, the direct neurotropic invasion is the possible mechanism of the anterior horn cells or the posterior horn cells of the dorsal columns. There's autoantibody production. This has been documented, anti-ganglioside antibodies, similar to other causes of AIDP. And then the third category is critical illness-related neuromuscular abnormalities, or which is also known as IC-acquired weakness, which is of two broad categories, polyneuropathy and quadriplegic myopathy. So in the direct neurotropic invasion, there's hypogeusia, which is loss of or disturbed taste, hypoosmia, loss of smell, and then there's autoimmune polyneuropathy, of which Guillain-Barré syndrome and AIDP are the most prevalent. In Guillain-Barré syndrome, there's a syndrome of ascending weakness of muscles, along with loss of deep tendon reflexes, and same with other causes of AIDP. A rare variant of Guillain-Barré syndrome called Bickerstaff's brainstem encephalitis has been documented in case reports. It is characterized by ascending weakness causing quadriparesis, but along with ophthalmoplegia and hypersomnolence. And in this particular case report, actually the CSF was positive for anti-ganglioside antibodies and showed albumin cytological dissociation that you see with Guillain-Barré syndrome, where there's high protein levels but low cell count in the CSF samples. So in symptoms, again, we talked about the pattern of weakness. It's ascending. It has sensory motor peripheral nerve symptoms like numbness and paresthesias and tingling. There is decreased deep tendon reflexes, and they were documented in by the third week, day 21 to 25, after the onset of SARS. The nerve conduction studies that were done on these patients showed temporarily reduced compound muscle action potential amplitudes, and the EMG showed acute denervation with increased polyphasia, indicating a prolonged phase of repolarization. Now, this is far more common, this slide, because over the last few months, as we've dealt with ICU patients in the COVID unit, we obviously deal with sedation, analgesia, neuromuscular paralysis, corticosteroid use. All of these are risk factors for developing this horrible complication of critical illness-related neuromuscular abnormalities. Polyneuropathy and quadriplegic myopathy is quite common as the duration of mechanical ventilation increases. Due to the effects of very common medications that we use, such as neuromuscular blockers, infusions of cis-atracurium and rocuronium have both been associated with this. In fact, studies prior to COVID-19 have shown that even single doses of neuromuscular blocking agents can predispose a patient to developing long-term critical illness neuromuscular abnormalities. However, these sometimes are essential medications to use in severe refractory hypoxemia. Some medication effects, such as the lopinavir, ritonavir, ribavirin, have known complications of polyneuropathy. We haven't used them much. And then nutritional deficiencies that go along with being critically ill, such as trace elements, zinc and copper, selenium, as well as vitamins, vitamin C and D, are associated with the risk of development of ICU-acquired weakness. So this is interesting. This is from a review in Lancet from last month. I urge you to read that article. It's a very good review article on neurological manifestations of COVID-19. It not only describes these syndromes that I went over, but also kind of elaborates at what phase of illness it can be more prevalent based on data extrapolated from SARS-1 and the MERS, as well as the COVID-19 case reports. So the viral RNA, obviously, we know that PCR is positive for some time. And as it is positive, you start developing the IgM antibodies, which are the acute antibodies, and later on the IgG antibodies. The syndromes of encephalitis and myelitis can present on the spectrum between day 0 to up to day 14, and then the incidence starts to slow down as the IgG antibodies go up. Acute demyelinating encephalomyelitis, the dreaded complication, can happen at any time, but mostly after 7 days, and can be can be presented as in those autopsy specimens. They were seen in 21 to 24 days later. Guillain-Barré syndrome or AIDP can develop at any time during this phase of illness. And then obviously cerebrovascular disease from get-go. Now in Guillain-Barré syndrome, they also go before symptom onset. And now this is based on prior knowledge that we have from viral pneumonias and viral infections, showing that that the patients can present with Guillain-Barré syndrome or AIDP, and then later on be diagnosed with a viral infection. Let's talk about seizures. We have seen seizures in our patients, not infrequently. I would say that the incidence is obviously low, is probably less than 1% of our patients, but when they're happening both generalized or focal seizures. Seizures can be secondary to brain pathology, encephalitis, meningitis, cerebral edema, or microvascular inflammation, but it could be secondary to some therapy side effects, hydroxychloroquine, antiviral agents, and then patients who are on prolonged mechanical ventilation, and as we're trying to wean them off sedation and analgesia, they've been on high doses of benzodiazepines in some circumstances, and you try to wean them off, and they can get withdrawal seizures. It is a one should have a low threshold for treating and detecting seizures. In a series of cases for non-convulsive seizures and non-convulsive status epilepticus, in a neuro ICU, the incidence is almost 30%. Like if the patients are admitted with a brain injury and they're admitted to the ICU and they're under sedation and analgesia on a ventilator, there's a 30% chance that they could be having subclinical seizures that can only be detected by EEG or a continuous EEG. In a medical ICU, like a COVID-19 ICU, the incidence in the same series was about 10%, 9 point some percent. So it's not insignificant. 1 out of 10 people could be having seizures. So patients who are unexplained, have unexplained loss of consciousness and are not waking up, have some weird twitching going on their toes or lip smacking or something like that while they're on the ventilator, it may be very important to detect seizures by doing an EEG immediately, or if your hospital or facility has the ability to do continuous EEG monitoring, that would be the way to detect it. Traditional anti-seizure therapy is employed, including phenytoin and other agents as such. So we're not going to talk in detail about that. Now, I want to talk about delirium because this is a project or a process that is very close to the intensivist's heart. Delirium is described, and the traditional delirium definitions are available everywhere in up-to-date or textbooks of medicine, and everybody has different definitions. But we now know that we don't hardly ever use the term encephalopathy anymore. We now know that there's 2 distinct types of delirium. There's hypoactive delirium and there's hyperactive delirium. In hypoactive delirium, it includes encephalopathy, where the brain is depressed, the neuronal transmission is depressed because of either uremia, azotemia, hyperammonemia, and then there's hyperactive delirium, in which the patient is agitated, confused, and combative, and whatnot. So delirium is defined as an acute brain failure syndrome, like other multiple organ failures, acute kidney failure, acute respiratory failure. Delirium is acute brain failure, and it has three important components. There is decreased cognition, which includes memory deficit, disorientation, language defects, visual and spatial disturbances, and disturbances of perception. These are more pronounced when the patient is already on a ventilator and is likely to moderately sedated. The second is disturbed attention and awareness, and this encompasses the hypoactive delirium and hyperactive. Hypoactive meaning they're encephalopathic and they're out of it, they're in a coma-like situation because of very high ammonia or high urea levels. Or they have the third category, which is psychomotor or behavioral disturbances, where they are extremely agitated, confused, thrashing around in the bed, trying to pull out their IVs and trying to extubate themselves. And even if they're not intubated, they are psychologians that are acting on this, from metabolic disorders to drug side effects to sedation analgesia. But the prevalence in COVID-19 patients is what is astounding. So delirium is defined with this definition is actually found in about 20 to 28% of all critically ill patients, especially the mechanically ventilated one. It is an independent predictor of length of stay and mortality, and has a high incidence in the hypoxemic patient on the ventilator. Hence, high incidence is expected in COVID-19. The data for actually using this definition and describing delirium is not that prevalent. Our institution, where we conducted the study, it's being published this month. It basically we looked at our 144 COVID-19 ICU patients. This is only for ICU patients. And in those 144 patients, we found delirium in 106 patients, which is about 73%, which is very, very high compared to all other critical care series. And this was, as you can look at all these comorbidities, insurance status, and ethnicities, the numbers are almost similar in these subgroups, indicating that regardless of the severity of illness, which is described by the Apache 2 score, the delirium incidence is significantly high in sicker patients, and is an independent predictor of mortality. So it predisposes to the development of the post-intensive care syndrome, which I will talk about in my next talk. So there's a management bundle to counteract delirium, and this ABCDF bundle was actually described at our institution by one of my colleagues a few years ago, and was published in JAMA and other major journals. The 6 components include to assess, prevent, and manage pain of patients. Providing correct analgesia to ICU patients is very important. Both spontaneous awakening trials and spontaneous breathing trials. Choose the correct analgesia and sedation. We'll talk about it in our next talk. Assess delirium, and I'll show you the next slide to show you how you assess delirium. Early mobility of patients, getting them to in the ICU, trying to get physical therapy to the ICU rather than wait for them to get discharged from the ICU, and involve the family in motivating and providing the positive reinforcement to the patients. To assess delirium, there is a scale known as the CAM-ICU, or the Confusion Assessment Method, in the ICU flow sheet, and I'll leave the slide up for you, and you can take a look at it, and I can email you this. Whoever wants to see this presentation later on, I can email it to them. But it's a series of 4 steps. If there's a change in fluctuating course of mental status, if there's inattention, if there's altered level of consciousness, or if there's disorganized thinking. And based on that, there's 4 scoring systems which show that the patient is not confused or delirious, and the patient is, again, in this not confused delirious of 0 to 2, if there is more than one score, or the total score is more than 2, and they are on sedation or their altered level of consciousness, then there is delirium is present, and so on and so forth. This scale has been validated in many studies, and we keep this an easy tool for the nurses at the bedside to assess patients daily for delirium. So let's talk about management of all these neurological manifestations before we switch to the next presentation. Obviously, you need general supportive care. All of the ICU issues, mechanical ventilation and IV fluids and care of the kidney failure, liver failure, all those things have to be done. COVID-19 specific therapy should not be withheld or changed just for the basis of neurological manifestations. Although we'll talk about some immune modulator and immune suppressive therapy that can use for specific neurological problems. Delirium management we already went over, and seizure management. These are the 5 components of neurological management in the ICU. In AIDP, or Guillain-Barré syndrome, or autoimmune encephalitis, the treatment described in the non-COVID patients or other viral infection patients is of 3 basic components. One is intravenous immune globulins, the second is plasma exchange, and third is steroids. So in IVIG, the doses have ranged anywhere between 0.4 to 1 gram per kilogram per day. The side effects are anaphylaxis, aseptic meningitis, acute kidney injury, and hyperviscosity. Plasma exchange should be done early on of the onset of the neurological problems. Whenever the neurological symptoms are happening and you diagnose them with an AIDP or autoimmune encephalitis, it should be done within 7 days of that. And the recommendations are to do 4 to 6 plasma exchange treatments over 10 days. So they can be every alternate day, or 2 or 3 stacked in the beginning, and then every other day. Side effects are obviously coagulation abnormalities from plasma exchange, hypofibrinogenemia, and DIC, and then vascular access problems, because in the ICU patients, sometimes you need a large bore dialysis catheter, 12 to 14 French, to do plasma exchange. The dose for corticosteroids is not clear in these situations, and it's all based on case series and anecdotal experiences. And it's methylprednisone has been mostly used in all these experiences, and there's questions whether standard dosing 1 milligram per kilogram per day, or a pulse dose such as like a gram a day in divided doses, or a single dose, or is useful, but no robust data exists on that. So in summary, neurological manifestations of COVID thankfully are in low percentage, but because of the sheer number of patients out there, we're going to see in our practices, all of us are going to see a few patients manifesting as either central nervous system or peripheral nervous system disorders, and it's very important to recognize them, and it's very important to not forget that the general care, which includes stroke care and encephalitis and anti-inflammatory care, should not be any different than if you were not seeing a COVID-19 patient. I was going to do question and comments, and we can do that, or we can switch to the next presentation. It really depends on the organizers.
Sir, it's up to you. If you would like us to ask the questions related to this first, we can do that. But if you want to continue, we can ask them in the end.
Okay, let's do that. Let's continue questions at the end. All right, so let me do the next presentation. Okay, so you guys can see it okay? All right. So critical care issues in COVID-19. Let's This first slide is the same as the previous presentation, which shows that when there is hypercoagulation and hyperinflammation from COVID-19, it has systemic effects because of the vascular involvement. So brain, heart, kidneys, liver, and then thrombosis, small vessel or large vessel, is the main problem in COVID-19. So manifestations of severe COVID-19, when we talk about topics of discussion, I want to go systematically and in an organized fashion, go over these 5 broad things. And since we are constrained for time, we cannot talk about everything in detail. I am very, very glad that Dr. Zille Humayun was able to go over these COVID-19 specific therapies in much detail yesterday. It was an excellent lecture, and that saves me the trouble of explaining some of these things in more detail. But we'll talk mostly about the manifestations of severe COVID-19, including pulmonary and systemic manifestation, talk about some of the stratification and risk scores of illness. We'll talk very importantly about how to oxygenate the COVID-19 patient, because that's what kills the COVID-19 patient, hypoxia. Intubation and mechanical ventilation we'll touch on. I understand that the audience is not all critical care doctors, and so I will try to speak in broad terms of intubation and mechanical ventilation. We'll talk about COVID-specific therapy in the ICU, and then the general critical care of the COVID patient. So in the COVID-19 crisis currently, 17 to 35% of all hospitalized patients are admitted to an ICU. And the most common reason is acute hypoxemic respiratory failure. The most common symptom is fever to 90%, dry cough is 60 to 86%, and shortness of breath is seen in about 53 to 80%. Fatigue is 38%, nausea, vomiting, diarrhea, primary GI 15 to 39%, and myalgia is seen as 15 to 44%. The non-classical symptoms, isolated GI symptoms or olfactory gustatory dysfunction, 64 to 80% of people, they have loss of taste, and that may be the sole presentation in about 80% of patients. So about 25% of infected patients have comorbidities. But about 60 to 90% of hospitalized infected patients have comorbidity. So if you have a comorbidity, you have a high chance of getting admitted to the ICU. The comorbidities most prevalent are hypertension, 48 to 57%, diabetes, cardiovascular disease, chronic pulmonary disease like COPD or asthma, chronic kidney disease, malignancy, and chronic liver disease in order of frequency. The mechanism of viral infection of the host airway cells is described yesterday, and I'm going to briefly touch on it. The SARS-CoV-2 virion with this viral RNA has a spike protein, the S protein, and acts on the ACE2 receptor, or the transmembrane series protein receptor, the TMPRSS2 receptor on the host cell membrane. It enters the host cell via endocytosis, releases its RNA, and then uses the cell machinery to replicate itself and assemble more virions. So one infected host cell can create hundreds of new virions, which rapidly progress the infection. In the early stage of COVID-19, the bronchial epithelial cells, type 1 and type 2 alveolar pneumocytes, and the capillary endothelial cells are infected, and that starts the inflammatory response. There is recruitment of T lymphocytes, monocytes, and neutrophils, which in turn release some cytokines such as TNF alpha, interleukin 1 and 6, and that's along with the messages inflammatory cascade. As the disease progresses, the activation of the complement system, the kinin-kallikrein system, hyaline membrane formation, influx of monocytes and neutrophils, and activation of the coagulation pathway lead to a combination of pulmonary edema and microvascular thrombosis in the pulmonary capillaries and in the large vessels later on. So when we talk about the pulmonary manifestations of COVID-19, acute hypoxemic respiratory failure is the main complication. The PaO2, by definition, acute hypoxemic respiratory failure is PaO2 less than 60 on 21% FiO2. And when the patients develop ARDS criteria, we use the Berlin definition of ARDS, which is acute onset within 7 days, development of bilateral pulmonary infiltrates on chest X-ray and CAT scan, and then a PaO2 to FiO2 ratio of less than 300 being mild ARDS, less than 200 being moderate, and less than 100 being severe ARDS. And the fourth criteria for ARDS definition is there should be no evidence of left heart failure or cardiogenic pulmonary edema. A classic CAT scan from a patient with ARDS from COVID-19. In this patient, there is pulmonary fibrosis also developing, and there is evidence of barotrauma with pneumomediastinum and bilateral ground glass opacities. So systemic manifestations, other than the non-pulmonary manifestations of COVID-19, acute pneumonia seen in 75%, ARDS in 15%, acute liver injury, which is seen in about 19%, which is elevated AST and ALT and bilirubin levels. We see it almost in 1/4 of our patients. This series said 19%, but I think it's more common than that. Cardiac injury by measurement of troponin levels is seen in about 7 to 17%. Acute heart failure, systolic heart failure, dysrhythmias, and myocarditis have been described in COVID-19. Prothrombotic coagulopathy, including venous and arterial thromboembolic events. This number is described in total as like 10 to 25%. As I'll show you our data, this number may be higher in the venous circulation. Acute kidney injury is seen in about 9 to 10%. Neurological manifestation, we went over that in the last presentation, is about 8% of patients have decreased level of consciousness, and 3% of patients have the cerebrovascular disease. 6% patients present primarily with a septic shock-like picture with COVID-19. And then the rare complications, which Dr. Zille Humayun talked about yesterday, were macrophage activation syndrome or hemophagocytic lymphohistiocytosis, can be the main manifestations of systemic COVID-19. Some of the scoring systems that are out there. So SOFA score, which is the most common scoring system used in COVID-19 patients. There are many scoring systems in critically ill patients, from Apache 2 scores to the MODS, multiple organ dysfunction score. Apache 2 has, there's Apache 3 also. But the SOFA score is the most commonly used because of its ease of using, its validation in septic shock, and it's used in the septic shock definition, as well as because most of the studies that are being with COVID-19 ICU patients are using actually the SOFA score system. So in SOFA score, there is scores are from 0 to 4, obviously 4 being the sickest and 0 being the least sick. It looks at the respiratory characteristics, which are the PaO2 FiO2 ratio based on the blood gas. A surrogate for that, as Dr. Zille Humayun mentioned yesterday, could be the O2 saturation and FiO2 ratio if blood gas testing is not available. But in general, if you're meeting the criteria for severe ARDS, which is less than 100 PO2 FiO2 ratio, you have a level of 4. The second is the platelet level. A platelet level, as it drops in severe illness, the scoring system, the scoring level goes high. So a platelet less than 20, platelet count less than 20 has a scoring system of 4. Liver dysfunction, and it is defined by bilirubin levels. If the bilirubin level is going up more than 2, the score level goes higher than 2. If the bilirubin is more than 6, it's at 3. And if the bilirubin is more than 12, then, and this is in milligram per deciliter, but we have the values in micromoles per liter for those who use that. If it's more than 204 micromoles per liter, the level is, the scoring system is 4, which is severe illness. Cardiovascular wise, if the blood pressure, mean arterial pressure is more than 70, you're 0. If it's less than 70, you're 1. However, when you start using vasopressors, dopamine, epinephrine, or norepinephrine, then the scoring system goes high, and at a high dose of epinephrine, norepinephrine, or dopamine, the levels are, the number is 4. You have the level of consciousness score, which is the Glasgow Coma Scale, and pretty self-explanatory. If the GCS is less than 6, or if the patient is in a high-grade coma, the score is 4. Acute kidney injury, very important component of the SOFA scoring system, and based on the urine output as well as the creatinine level. And you can see that the urine output is less than 200 mLs per day, and the creatinine is more than 5, as a SOFA score of 4. So it's important to stratify our patients based on SOFA system and when they're admitted to the ICU, so that the therapies can be geared toward that. There's triage priority, there's priorities to intubate, and so on and so forth. So since acute hypoxemic respiratory failure is the main cause of fatality in 70% of COVID-19 deaths, we'll talk about oxygenation strategies. We'll talk about non-invasive first, and then we'll talk about the mechanical ventilator strategies. So I'll talk in general terms and then also specific to what we use in our institution. So the oxygen through a nasal cannula or a high-flow nasal cannula are the recommended first-line therapies. It has been shown now that high-flow nasal cannula may be far superior than other methods of non-invasive methods of oxygen delivery, such as a face mask, a face stent, a non-rebreather mask, and even BiPAP or CPAP, just because the risk of aerosolization is much higher in the room, in the ICU room, with these other devices. That in turn can translate into less physicians and nurses and respiratory therapists going in the room, less frequency of adequate bedside care being provided, delay in donning and doffing PPE. And so in our institution, we try not to use these maneuvers in general. We stick to the high flow nasal cannula, and at some point we have tried patients on BiPAP as well, with the biofilter in place to minimize the risk of aerosolization. So high flow nasal cannula, the principle is that there is an air oxygen blender which allows FiO2 from 21% to 100%, and this generates a flow of about up to 60 liters per minute. Traditional nasal cannula can go up to from 2 liters to up to like 8 liters, 10 liters per minute, even up to 15 liters per minute. But there's the effectiveness of FiO2 delivery is not as high when patients' oxygen is turned up to 60 liters per minute. The gas is heated and humidified through an active heated humidifier and is delivered by a single limb heated inspiratory circuit. The patient breathes adequately heated and humidified gas, and the diameter of the nasal cannula is actually pretty wide. several devices are available, I've listed most of them here, but in general, there are three different types. One is the air oxygen blenders, which is the most common one used. There are turbines, and then there's the Venturi effect machines, which kind of generate which require a negative pressure to be generated to increase the flow. So this is the most common and what we use here in our institution, where we have the ability to dial up the FiO2, and along with that, dial up the flow rate, which is I forgot to add that picture. In this machine, the vapotherm machine, you can actually use a dial to go up on this shows 35 liters per minute and 40% FiO2 on this patient, and this is the temperature set for humidified air, which is 37 degrees Celsius. So the mechanism is that at high flow, at about 30 to 70 liters per minute and a FiO2 of 30 to 100% with temp of 31 to 37 degrees Celsius, there is very high flow of oxygen going through the nasopharynx down into the trachea and the lungs. As a result of its high velocity, there is nasopharyngeal CO2 washout. There is the airways are kind of splint open, similar to CPAP, but not as obviously not as high pressure as CPAP, but there's positive pressure exerted on the airways. There is maintenance of the mucociliary function, and there is increase in the end expiratory lung volumes, increase in end expiratory and transpulmonary pressures, and decreased hydrostatic capillary alveolar gradient. Hence, not only improving the delivery of oxygen rapidly from the nasopharynx down to the alveolar level, but also providing some splint opening of the upper airways as well as the lower airways. With the COVID-19 crisis, the use of high-flow nasal cannula has resulted in prevention of intubation in a tremendous number of patients, and it's the main and primary method of oxygen delivery right now in ICUs. A nice mnemonic to remember: the mechanism of action is high flow, which is heated and humidified. It meets the inspiratory demands. Its functional residual capacity of the lungs increases. It's lighter, which means it's easily tolerable than CPAP or BiPAP. You don't have a mask on your face. There is oxygen dilution. It minimizes oxygen dilution because the flow is so high. And then there's washout of dead space because of high flow rate, leading out the washout of the pharyngeal dead space. The second technique, after providing oxygen through a nasal cannula or other devices, is prone positioning. In severe hypoxemic respiratory failure, in patients who are not intubated, the data currently published and out there, and our clinical experience is that if you intubate, if you prone a patient awake, non-intubated, it will improve oxygenation. The mechanism is pretty simple, that when the patient is supine, there is more disease distribution or more disease segments in the dorsal regions, and there is VQ mismatch because blood gravitates down to the dorsal regions in the supine position, and that's the diseased alveoli mostly down there. So there is ineffective gas exchange. Once you have them prone, there is shape matching because of gravity. There is more homogeneous spread of the blood flow in the lungs, ability to perfuse the healthy alveoli much better, and that effect is actually seen pretty rapidly as you prone the patient. This is an awake prone patient on a high flow nasal cannula. As you can see, it is the supine position. The dorsal lung is more diseased, and the ventral alveoli are over distended. As you prone them, you have more homogeneous alveolar inflation and much more diffuse distribution of the blood flow. This is an automatic proning device, which is we use for intubated patients only, but I thought I'd show it right here after I discuss the non-intubated ones. This is called the rotoprone system. This allows the patient, because manually proning a patient, especially when they're intubated, is very labor intensive. You require up to like 6 or 7 trained personnel, including someone who is watching the endotracheal tube, the central lines, the arterial lines, holding the patient's head in place, and then 3 people on each side doing a flip maneuver. The care of patients is difficult in terms of pressure sores and vascular access, and doing x-rays, and so there's a lot of practical issues with proning. Some of them are mitigated when we use a automatic proning bed. This allows, it looks pretty kind of like a torture device, where patients like strapped in like a very heavy looking equipment. But when it's flipped over, you can see that on the back, these are their basically doors of cabinets that you open up. And if you open these two, for example, you can examine the back and listen to the lungs. When you open these, you can actually look at the limbs. When you open the upper two, you can access the central lines and the IVs and do endotracheal tube care. The automatic machine allows the patient to be placed only one time in this machine and then strapped, and all these channels are available for IV tubings and the endotracheal tube in the ventilator circuit. And once you prone them, then you basically can prone them for as long as you want without having to do that physical labor again. The controls are all here. It can even allow you to put the patient on one side or the other in case they have heterogeneous lung disease, where one lung is diseased more than the other, and you find out that when their right side is down, they're oxygenating better, or their left side is down, and you can adjust the bed that way. So we found this to be much more effective. In obese patients, again, it is just a first time effort to put it in this bed, but then it becomes so much easier rather than proning them and supining them, which is supposed to be done about 12 to 18 hours a day. In this protocol that's listed here, in the first step, it says high flow nasal cannula combined with prone positioning in an awake patient for 16 hours a day. The same principle is applied for these intubated patients, which is about 12 to 18 hours a day. So the third mechanism, so the first mechanism was oxygen delivery through a high flow nasal cannula or other devices. The second was to awake prone them. And the third was to use inhaled pulmonary vasodilators. We have in our institution, the two agents we have are inhaled nitric oxide and inhaled epoprostenol. And then obviously other centers and other institutions have different inhaled pulmonary vasodilators. The mechanism in a non-intubated patient is to connect it to the console that has the epoprostenol drug to the tubing that is ultimately going to go to the patient. There's a one-way valve to it. There's a connector to the patient's mask, and there is a added nebulizer cup for the prostacyclin. The pathophysiology is very interesting. So as the patients develop disease in a segment of the lung, in the hypoxic region, the pulmonary vessels at the capillary level or even the arteriolar level or a venular level, they start getting vasoconstriction. So hypoxia induces pulmonary vasoconstriction. As you get vasoconstriction, you have increase in the right ventricular afterload. As there is vasoconstriction in the lungs, the right ventricle has a hard time pumping into the lungs, and the pulmonary artery starts getting dilated, the RV starts getting dilated, and you can get pulmonary arterial hypertension. As the heart is pumping, the right heart is pumping, it is diverting now blood to the more vasodilated segments, which are in the normal oxic regions of the lung, where there is not much disease going on. So again, like with the supine positioning, there is a mismatching and shunting of the blood into the areas which have healthy alveoli, and the diseased alveoli are perpetuating this vicious cycle of pulmonary vasoconstriction, which then is resulting in lower blood flow to those areas and worsening gas exchange. When you use inhaled pulmonary dilators, you have diversion of blood into the hypoxic regions as well as in the non-hypoxic regions of the lung. And there is vasodilatation in the hypoxic areas, which improves the perfusion of that area, obviously. But more importantly, there is the blood diversion becomes more homogeneous and more diffuse, and there is less pressure on the right ventricular outflow tract, and the pulmonary hypertension improves. As a result, as you increase the vasodilator dose, the more blood starts getting more diverted into the ventilated regions, and you start getting better oxygenation, and as well as better shunt fraction from the areas that were already vasodilated in the diseased alveoli. The clinical effect of starting an inhaled pulmonary vasodilator is that once you start nebulizing the nitric oxide or epoprostenol, you start seeing the oxygen saturation improve almost immediately. Within a few minutes, you start to see the SATs improve. So a typical severe COVID-19 patient that is not intubated will have a high flow nasal cannula hooked up through this circuit with a inhaled vasodilator and laying prone in the ICU bed without being intubated. That results in preventing intubation and improving saturation of a large number of our patients. So let's talk about invasive strategies now for oxygen delivery. As was mentioned yesterday, there was a lot of debate about whether severe COVID-19 patients should be intubated early or late. The general consensus now is that the approach to intubate immediately was not the correct approach that was employed in the beginning of the pandemic. We did not have a good understanding of how the disease works, what kind of pathophysiology is going on at the alveolar level, and we were using the same guidelines that are there for ARDS in general, where we're like, oh, if you want to do low tidal volume ventilation and provide high PEEP and cause the ventilator synchrony with the patient, you can't achieve all those things without intubating the patient. Hence, intubate as soon as possible. However, as more and more data came out from China and Spain and Italy and from Seattle and New York, it showed that the mortality of intubated patients was significantly high. And there were two questions in mind. Were the patients who were intubated were really very sick and that's why their mortality was high, or whether intubating them early was actually not a good thing? And I think a general consensus now is that intubating early is not a good thing because of all the things that go along with intubating early, including high-dose sedation, analgesia, neuromuscular blockade, vasopressor use, hemodynamic instability because of sedation and analgesia. And as I described, the non-intubation strategies such as high-flow nasal cannula, prone positioning, and inhaled pulmonary vasodilators can actually stave off intubation in a lot of these patients, and they start to recover. If you get them through the phase of the cytokine surge, the cytokine storm, the acute inflammatory phase, you can start improving their oxygenation and their need for intubation. But in any case, if you have to intubate, the intubation is considered to be a high-risk procedure. It has to be undertaken in an airborne isolation room. This is the protocol that we wrote for our institution. This is the one that we follow in our ICU. So it's high-risk procedures undertaken in an airborne isolation room. All personnel in the room have to use appropriate airborne and droplet PPE, which includes N95 or a PAPR mask. the procedure must be conducted with planning. You just don't go into it without, just take the equipment and rush into the room. There has to be a huddle between the nurse, the respiratory therapist, and the intubating person, the operator. All required equipment must be collected and taken into the room prior to the procedure to avoid opening the door and requiring recurring traffic of personnel during the procedure. Only essential team members in the room for the procedure. The procedure itself is going to aerosolize the virus. So we provide adequate pre-oxygenation through the nasal cannula. Bag mask ventilation or ambu bagging can generate aerosols, and so does laryngoscopy by inducing cough. So in case you need to use an ambu bag, which we recommend not using it, but if we have to use it, we try to use an exhalation filter, a biofilter, which was developed during the swine flu epidemic. We try to use that, but in general, we're trying to avoid doing ambu bagging. And because we want to minimize the cough reflex, all intubations should be done with rapid sequence using adequate sedation and neuromuscular paralysis to minimize coughing and easy airway visualization. The ideal recommendations are to use video laryngoscopy with a display separate from the blade to avoid proximity of the intubator's face to the airway. If a difficult airway is anticipated because of your pre-intubation evaluation, the patient has craniofacial defects or morbidly obese or has other anatomical problems, a flexible bronchoscope should be available with a video display or other tools for difficult airway in your cart, including an emergent crack kit should be there. Following placement of the endotracheal tube under direct guidance with a video scope, the confirmation using end-tidal CO2 may be used, but we don't use, like in general, we ambu bag patients and put the end-tidal CO2 filter on it. We don't do that for the COVID-19 patients. We just hook them up to the ventilator with the CO2 filter and see if there's a color change. Traditionally, we intubate and then we listen to breath sounds by ambu bagging. We're not doing that for the COVID-19 patients. We just look for chest rise once it's hooked up to the ventilator and then confirming it with either ultrasound or chest x-ray. The one thing that goes along with intubation is that when patients are being intubated for COVID-19, they're obviously very sick, and their level of illness has actually gone up. Their SOFA scores are very high. So remember the other things that go along with the SOFA score, which is hemodynamic instability and kidney failure. So it is very, very likely that these patients are going to require vasopressors, hemodynamic monitoring, and maybe renal replacement therapy, the continuous renal replacement therapy. So to minimize time and to minimize risk of exposure, we do, as soon as we intubate these patients, we do all these procedures at the same time, including a central line, arterial line, and a dialysis catheter in patients with acute kidney injury, almost during the same procedural go, so to speak, so that one X-ray is needed afterwards to confirm placement of all these devices. Once the patient is intubated with COVID-19, we have mechanical ventilator strategies. Now, we have been using the same guidelines that everybody else in the world have been using in general for mechanical ventilation in the beginning, which was that used the lung protective ventilation with low tidal volume and high PEEP to increase oxygenation and decrease the risk of barotrauma and volutrauma. However, it turns out that when you actually measure the airway pressures, the inflation pressures, such as the plateau pressure of these patients, these plateau pressures are actually not elevated as much as they would be elevated in, say, ARDS from pneumococcal pneumonia or from any other reason like aspiration pneumonitis. The stiffening of the lung parenchyma is not that prevalent in the early phases of COVID-19 induced ARDS. And this has been shown now in studies from Italy. They showed that there is more hypoxic pulmonary vasoconstriction as well as a interstitial inflammation rather than interstitial edema and hyaline membranes in the early phases, and that's why the lungs are not as stiff. So this begs the question that if their pulmonary compliance is normal or high, then what is the purpose of doing the lung protective ventilation, because the risk of barotrauma or volutrauma is going to be low. So based on that, we divide our patients into high pulmonary compliance patients which have normal plateau pressures and have only isolated COVID-19 pneumonia, no other coexisting bacterial pneumonia or other event like aspiration of vomit or things like that. And in these patients, since the main finding is hypoxic vasoconstriction, we try the pressure-controlled time cycle ventilation, which allows the patient to take spontaneous tidal volumes at a lower rate and allows for them to have better compliance. And the only thing we control is the inflation pressures and the timing of inhalation and exhalation. Generally, we saw that even if we measured the plateau pressures in these patients, they were not high. They were in morbidly obese patients, they were as high as 32 to 34, and in the normal sized patients, they were less than 30. In the low pulmonary compliance patient who have lung pattern injury similar to ARDS, traditional ARDS, because they had concomitant bacterial pneumonia or aspiration on BiPAP or something like that, we use the standard ARDS strategy, which is low tidal volume and high PEEP and measuring plateau pressures and titrating tidal volumes along according to the plateau pressures. So the goals of therapy are to improve the PaO to FiO2 ratio, to keep the PaO2 levels more than 55 to 80, to keep the SAPs at least greater than 88%, prevent acidosis, prevent barotrauma, and keep the oxygen index less than 25. This is our protocol for management of a mechanical ventilator and oxygenation management in severe COVID-19. We've obviously modified it as the literature has come around. This was started on March 1st, and now this is the latest version. This version is from July 2nd. So in this version, we can see that we diagnose the ARDS, measure all this PF ratio and PEEP requirements, follow the ARDS net PEEP FiO2 table. And there's mild ARDS, moderate, and severe, like we described in the definitions in the beginning. And we'll focus more on the severe ARDS. In the severe ARDS, we try in patients with high lung compliance, pressure control modes, including pressure control ventilation itself, APRV, or other similar modes. We keep the or inverse ratio ventilation, keep the plateau pressure less than 30, respiratory rate less than 20. And in patients with low lung compliance, we'd use the standard low tidal volume strategy with PEEP strategy based on the ARDS net table that I showed you. The patient has to have optimal sedation and analgesia. They should be prone position for about 12 to 18 hours a day, plus minus an inhaled vasodilator after intubation. Diuresis, if clinically indicated, that's kind of controversial because as Dr. Fazal described in the last talk, initially the patients may be volume depleted because of septic shock-like picture. But the best way is to do an echo on them and look at the LV and RV function and do an ultrasound for pleural effusions, and then gauge your volume therapy based on that, and consider inhaled pulmonary vasodilator more strongly in patients who have RV dysfunction. We try to measure blood gases initially in the first day every 2 to 4 hours, but obviously it's resource limited and we can use the surrogate, the oxygen saturation. In patients who have mild to moderate ARDS who are not intubated, we described this before, you do high flow nasal cannula and do awake proning, but with inhaled vasodilator plus minus. So if the patients have dyssynchrony with the ventilator, then we add neuromuscular blockade, including a bolus dose followed by a drip for at least 48 hours, the cis-atracurium drip. Cis-atracurium is chosen because of its ability to be eliminated by Hoffman's elimination, by plasma esterases, rather than by the liver or kidney metabolism. The prone positioning is, we have done it for almost more than 21 hours a day. If we manually prone them, we do that for more than 21 hours a day because it's so labor intensive to kind of flip them over. If we do it by the rotoprone bed, we do to 12 to 18 hours a day. If the current therapy is not working, basically, we then proceed on to ECMO or transfer to a patient to a center which has ECMO. Now, for ECMO or extracorporeal membrane oxygenation, we use two risk scoring systems, and that determines whether the patient is in a stage where you've tried everything, but now they're still not improving, and you have to think of this salvage strategy of ECMO. So one is the Murray score, which looks at the chest X-ray scores from 0 to 4, which is the 4 being alveolar consolidation confined to all 4 quadrants of both lungs. Hypoxemia score, which is the same as the PF ratio of less than 100 is a 4. PEEP requirement of more than 15. Respiratory system compliance when available, which is to calculated using PEEP and plateau pressure and whatnot. And then the score is calculated by adding the sum of each component and dividing the number of components used. So no lung injury is 0, moderate lung injury is 0.1 to 2.5, and then severe lung injury is greater than 2.5. So if you greater than 2.5 score, despite all the maneuvers that we did in the previous slides, then your Murray score is high enough to warrant consideration of ECMO therapy. Before you put someone on ECMO, the ECMO surgeon or the ECMO team will look at their RESP score, which is another score to know about, because it looks at the prognosis of what is the survival chances of this patient if they were put on ECMO. So just having the Murray score does not mean that they're going to actually, and you put them on ECMO, means that they're going to actually survive the illness. So if there is concomitant other features going on, such as bacterial pneumonia, asthma, CNS dysfunction, use of nitric oxide, bicarb drip, cardiac arrest before ECMO, all these have negative and positive scoring systems. It's a pretty elaborate scoring system. If the RESP score is greater than 6, that means that the survival could be more than 92% on ECMO. And if it's less than 6, if it's less than -6, then it's a risk class 5, which means that there's only an 18% survival chance in the best facilities, where ECMO is available, and the patients can be basically declined from being placed on ECMO. A little bit about the principles of ECMO. So the principle is the ECMO that we use for ARDS or for COVID-19 hypoxemia is the category of veno-venous ECMO. It means that there are two cannulas, very large. They're like chest tube sized. They're almost between 18 to 24 French, depending on the institution and depending on the manufacturer. But one of them is placed through the right IJ down into the right ventricle, close to the right atrium, close to the tricuspid valve. The other one is placed in the inferior vena cava. So the one in the inferior vena cava is pulling blood, which goes into a pump and is pumped to an oxygenator. The oxygenator is hooked up to an oxygen blender, which oxygenates the blood. Now, this is the entire cardiac output coming out of the patient, going through the pump, through the oxygenator, oxygenating the blood and returning it into the internal jugular venous catheter that's at the level of the tricuspid valve. Hence, oxygenated blood is being pumped into the right ventricle as opposed to deoxygenated blood, which is normally done. And the right ventricle then pumps out oxygenated blood into the pulmonary circulation. As we know, there is no gas exchange going on because of severe ARDS. So there is intrapulmonary shunting going on. The right-sided blood is returning to the left side of the heart without getting gas exchange. That's the main pathophysiology of severe ARDS. So when blood is returning to the left side of the heart on ECMO, it is actually oxygenated blood. And so the left heart is now pumping out oxygenated blood. And that is how you have improved the systemic oxygen delivery by using the the pathophysiology of the disease to your own advantage. Again, to summarize, the gas mixture with high oxygen is causing blood to flow from the right side of the circulation to the left side of the circulation through diseased lungs without getting the oxygenation from the lungs. If there is added oxygenation provided from the lungs, it's even better. As the lungs start to heal, as the ARDS starts to resolve, you start to wean down the ECMO. It is obviously very labor intensive and very invasive therapy because there are two large bore catheters that are central line-like catheters which are placed into the IJ and the femoral veins. So and the patients are connected to a pump and a oxygenator. So it is a lot of extracorporeal blood. The whole cardiac output comes out, goes through machines before returning back. So the coagulation cascade is activated, which is even worse in the COVID-19 patient because we know that it's a hypercoagulable state. So as a result, there is bleeding, hemolysis, infection, clot formation, all sorts of complications, including pump failure, decannulation, air embolism, cardiac arrest. A lot of these studies have shown improvement in survival based in viral pneumonias. Particularly the Caesar trial showed improvement in survival in viral pneumonias by using ECMO. Our own current data is we used ECMO in about 22 patients, and of those patients, so far we've discharged 14 patients, and there's still inpatient 4 patients, and there are 2 patients that died. This is our data as of this past Monday. COVID-19 specific therapy is employed in the ICU, obviously, in the critically ill patient when you're doing all these things concomitantly, you're doing COVID-19 specific therapies. There are basically 6 categories of COVID-19 therapies. There's antiviral therapies such as remdesivir or favipiravir. There are antibodies therapies such as using IVIG or convalescent plasma. Anti-inflammatory therapies such as using dexamethasone and other steroids and statins. Targeted immune modulator therapies against, say, interleukin-6, such as tocilizumab and serulumab and anakinra and ruxolitinib, which is a newer one. Anticoagulant use, using either full anticoagulation with unfractionated heparin or low molecular weight heparin, or using even TPA, which is a trial being conducted in New York right now. We're looking at low-dose TPA infusion to counteract the microvascular pulmonary thrombosis in COVID-19. And then antifibrotic agents, which I wanted to mention because our center is part of that trial, which is a tyrosine kinase inhibitor called the imatinib, which acts on different pathways. So this is a very busy slide, and obviously we're not going to go over in detail, but it shows the different steps of the COVID-19 virus infecting the alveolar cell and different pathways of inflammation being activated, including interleukin-6, which is counteracted by tocilizumab, and then the TMPRSS2, which is the camostat and nafamostat, which are experimental drugs. Endocytosis, which is affected by hydroxychloroquine. It was thought that it was effective. The viral RNA itself attacked by the lopinavir, ritonavir, disulfiram, remdesivir, acting on the RNA-dependent RNA polymerase, and so on and so forth. So some of the unproven therapies right now that we are now not using in the ICU as opposed to in the first month are hydroxychloroquine plus azithromycin, or azithromycin by itself. There are several large studies that have advised or against it or shown no benefit of using these strategies. However, there are still a few randomized control trials going on, so we can't completely say that these are disproven therapies. Lopinavir, ritonavir, ribavirin, again, the studies that are out there right now show no benefit, but the Chinese experience is different, and we wait for more descriptive studies to come out. I'll just talk about remdesivir and tocilizumab and steroids because those are the mainstay of the therapy in our ICU patients right now. The remdesivir use is based on this large trial, the ACT-1 trial, which was published in the New England Journal, which basically shows that patients who were less sick benefited more from remdesivir. Overall, there is a benefit of improved symptoms and improved duration of illness with remdesivir compared to placebo. In patients who were on oxygen, you can see that benefit again after the first 12 days of therapy. You start seeing the benefit more. In patients who are intubated or on high flow oxygen, the benefit was not that marked, except in the early phases of the illness. So based on this data, the investigators concluded that in patients who received, and this is a study of more than 1,000 patients, it showed that the recovery time is improved with using remdesivir. However, there was no impact on overall mortality. Slightly improved the remdesivir, 7.1% with remdesivir versus 12% in the placebo group. And the serious adverse events were 21% of patients who got remdesivir, and they included anemia, acute kidney injury, hyperglycemia, and elevated liver enzymes. With tocilizumab, the anti-interleukin-6 agent, it's a monoclonal antibody against the IL-6 receptor. It is unclear about the timing of the. So that is the biggest question we have, is that is it supposed to be administered early? With remdesivir, as Dr. Zileo pointed out, in sick patients, you want to give it early on because that's when the virus is replicating. That's why when you want to attack the RNA-dependent RNA polymerase and attack the viral replication. However, with the interleukin-6, people can have the acute cytokine storm or the macrophage activation or anything resembling a systemic inflammatory syndrome later in the course of illness, early in the course of illness, in the mid phase of the course of illness, and that's when it becomes unclear of when to give the tocilizumab. Does measuring interleukin-6 level help? It can, and so we try to stratify using tocilizumab based on the IL-6 level. The problem is with IL-6 level is obviously the risk of superinfection. The current trial that's going on, the large trial, is called the tocilizumab in COVID-19 pneumonia, the COVEB trial, and that's going to be the big randomized control trial that, when published, will answer some of our questions. The current data is based on this cohort study published last month, and it shows that in people who are mechanical ventilated, there is much more clinical improvement and shorter duration of mechanical ventilation, and overall there is a shorter duration of vasopressor support when people have been placed on tocilizumab. Obviously, it's a small study of 51 patients, and the data was not powered to show a difference in mortality. Steroids is obviously the news these days. Even before the steroid data came out, the dexamethasone trial, the recovery trial came out, it was clear that people were using steroids for severe illness, because we know there's severe inflammation going on at the alveolar capillary interface, and there's severe ARDS going on. And when your patient is so sick that they're on the ventilator and they have severe hypoxemic failure, you tend to use whatever means are available. So despite the guidelines in the beginning saying that please do not use corticosteroids in SARS-CoV-2, that was the guidelines that came out in December, January, February from different sources: WHO, CDC, Society of Critical Care Medicine, American Thoracic Society, the British societies, everything. Well, everybody was saying don't use steroids, but actually when people studied it, it found out that even before the guidelines, 50% of patients, more than 50%, were given steroids in MERS and SARS and SARS-CoV-2 for their anti-inflammatory effect. This is mostly based on the ARDS data, non-COVID ARDS data, of the mainly the DEXA ARDS trial, which used dexamethasone, which was published last year in 277 patients, that showed improvement in survival in the steroid or dexamethasone group. So in COVID-19, in June, the trial was published, the recovery trial looking from England, that looked at 2,100 patients receiving dexamethasone out of 6,000 patients receiving COVID-19 therapies. And the mortality difference was statistically significant, 21% versus 24%. And the mortality reduction was 35% in mechanically ventilated patients and 20% reduction in non-mechanically ventilated patients. A similar trial, called the GluCOVED trial, is looking at methylprednisone in 85 patients who are not intubated, only on high flow oxygen. And again, the preliminary results that are being published show improvement in survival in the non-intubated patients if they got methylprednisone early. In that study, they're using methylprednisone at a dose of about, I think, 40 milligrams IV Q8 or Q12. This is data that we are publishing. It's going to be published this month. We looked at our patient group of 136 COVID-19 patients just in the month of March and April, and we saw that in the steroid group, in the non-intubated patients, the patients who received steroids, none of them died. The number was 16 patients, none of them died, and in the patients who did not give steroids, more than half of them died if they were not intubated. In the intubated group, again, the number of survival patients is far greater than the no steroid group. In our study, 45% of patients got methylprednisone. The rest got a combination of either dexamethasone, hydrocortisone, or oral prednisone. Convalescent plasma. Again, the biggest question is, in an ICU patient with severe hypoxemic respiratory illness, what is the best time to give it? Is it early on? Is it late? Is it in the mid phase? And again, the one trial that is out there from China is the trial published in JAMA last month that showed that in convalescent plasma, there is slightly improved tendency for symptoms to resolve, but the overall, and it's much more, the difference is much more evident in sick patients in severe disease, but in life-threatening illness, when people are intubated, there is not much difference in giving plasma versus placebo. So the subgroup of patients that could benefit from convalescent plasma are patients who are intubated to the ICU, are patients who are admitted to the ICU but not intubated yet and have severe disease, and the case can be made for early convalescent plasma administration. However, there are several case reports out there for late administration. In our institution, we are giving it early on at the time of diagnosis of COVID-19. If they're in the ICU requiring high flow oxygen, we start them on remdesivir, convalescent plasma, and dexamethasone or other steroids almost at the same time. And then the tocilizumab we base on the interleukin-6 levels. Some general principles of ICU care. There is sedation and analgesia. The benzodiazepines have long-term problems, and so we're trying to use more of the alpha-2 receptor agonist, dexmedetomidine. Pain management is very important, so opioids either as infusions of morphine or hydromorphone or fentanyl or scheduled doses. Propofol is used less because of hemodynamic instability, and because many of these patients, when they're intubated, they require intubation for quite a number of days, and so long-term use of propofol is not recommended. We talked about delirium and ABCDF bundle earlier. Keep an eye out for nosocomial infections. Not everybody gets sick or further sick from a cytokine storm in COVID-19. Like any other viral pneumonias, there is superimposed bacterial infection, particularly in those patients who got tocilizumab. So culture them, treat them empirically with broad-spectrum antibiotics. Try to measure hemodynamic monitoring with echo or other hemodynamic tools when you're using vasoactive drugs. There's a cardiac arrest protocol in place, which I'll describe in a second, for COVID-19 patients, and we'll talk about early nutrition, glucose control, and then anticoagulation a little bit. So we already talked about delirium in the previous presentation, so we're not going to go over in detail. But for cardiac arrest, code blue or cardiac arrest call, we have a whole protocol because it is a very aerosolizing procedure to do CPR on COVID-19 patients. So again, a plan in place should be in place before you are starting to take care of COVID-19, especially when there is a surge of patients coming in. So I'm not going to go over the protocol in detail as it is several steps, but in general, only essential people should be there in the code room. People who can intubate, people who can, one or two people who can switch between chest compressions, and a person who can push medications while chest compressions and airway care is being done. When the patient is on the ventilator and they have a cardiac arrest, we do not turn off the ventilator. We continue the oxygenation through the ventilator rather than doing ambu bagging and continue chest compressions and vasoactive drugs. If they are not on the ventilator when they code, one of the persons puts a drape or sheet on the patient's mouth and face while CPR is being conducted, and then while wearing an N95 or PAPR, you put in an oropharyngeal airway like a laryngeal mask airway, followed by intubation only once the ROSC or return of spontaneous circulation is achieved. I'll be glad to answer more questions about the cardiac arrest in the question and answer sessions. Anticoagulation in COVID-19, we know it's a hypercoagulable state. Everybody has told you that in many of the lectures. And we've seen DVTs and superficial venous thrombosis and pulmonary emboli, arterial thrombi. The incidence is anywhere between 10 to 42%. The D-dimer level correlates. Now, the current recommendations, because there's lack of randomized controlled trials, it is unclear whether systemic anticoagulation is for everyone. However, many of the hospitals employ full anticoagulation. In our center, we use the D-dimer level, and we provide high-dose prophylactic anticoagulation with Lovenox or low molecular weight heparin or heparin, and then full anticoagulation or on patients whose D-dimer levels are exponentially rising or absolutely high. This is our data we published last month of 45 patients on which we had a 42% DVT rate, and we used these DVT prophylaxis regimens, including 40 milligrams Q12 of low molecular weight heparin, 30 milligrams Q12, 40 milligrams Q12, and then unfractionated heparin at 5,000 or 7,500 units every 8 hours. And we found out that our positive predictive value for a positive ultrasound, this is the date of ultrasound, the positive predictive value for a positive DVT study goes up as the D-dimer level goes up. So the sensitivity and specificity is very, very high over the 5,000 or so. So if a person's D-dimer is 5,000, we put them on full anticoagulation. If there's less than 5,000 but more than 2,000, we screen them for DVT or pulmonary embolism. And if it's less than 2,000, we then follow the D-dimer levels and see if they're rising. Hyperglycemia is very common in COVID-19 because of obviously the pre-existing diabetes that is seen in almost half the patients and the pre-diabetic states. And obviously now, because everybody's now receiving dexamethasone, not just 50% of patients after the recovery trial. But then there is also SARS-CoV-2 induced hyperglycemia, because we found out that the ACE2 receptors is also on the pancreatic beta cells. And that induces severe hyperglycemia and increased insulin resistance. We know hyperglycemia is an independent predictor of mortality in the critically ill. There are multiple studies. There's studies that look at blood glucose levels from 140 to 180, 70 to 150, 80 to 110. Different goals of therapy are described in different patient populations. 80 to 110 is in cardiac surgical population, 70 to 150 is in general ICU patients, and 140 to 180 is in medically critically ill patients. But we found out, this is our data. Again, we're publishing our data on glycemic control in COVID-19 patients, and we're looking at 130 ICU patients comparing with 490 non-COVID ICU patients since January of this year. And we found out that this is the time in which the same insulin treatment regimens are used, either NPH insulin or sliding scale insulin or insulin drips. With the same regimens employed, there is a higher incidence of glucose out of range in COVID patients. And insulin resistance is the explanation for that. It is very difficult to control the blood glucose in these patients, and that may be the reason for their hyperglycemia and again mortality. So this in general was the main thing that I wanted to touch on. Now, as far as overall outcomes go, based on what we've talked about, the antiviral, anti-inflammatory therapy, steroids, timing of tocilizumab, glucose control, and the anticoagulation, we found out that if we do everything by a protocolized fashion, like it should not depend on who the ICU doctor is. We're a bunch of doctors, and many of us are actually going to get sick from this and be on the other side of the ICU bed. So the protocol has to be the same, we decided in our group, regardless of who is the clinician at the bedside. So it should not depend on whether I am taking care of the patient or some other. We follow these protocols. And once we implemented protocols, we actually look at our data and we look at, this is initial, we're looking at 153 of our patients, of which 109 were on the ventilator with COVID and 44 with non-COVID. And we found out that our overall mortality was 28%. It was slightly higher in the mechanically ventilated one, 30%, but in the non-mechanically ventilated was 22%. This is, in mechanically ventilated patients, this is the lowest mortality described so far. The most recent was 35 to 40% in the United States. So we're trying to show here in our study that protocolized approach, where a doctor, nurse, respiratory therapist, pharmacist are all involved at the same level in the care of the patient, is far better. The other thing we are also, the mortality is not just inpatient mortality, it's long-term. The other thing is we're looking at the post-intensive care syndrome, which is a very well-known entity, which encompasses mental health, cognitive impairments, and physical impairments. We know about the physical impairments. These patients will get pulmonary fibrosis and have oxygen dependency, physical disabilities and neuromuscular abnormalities for a long time. But at the same time, because of delirium, they have impairment of executive function, memory, and actually increased risk of development of Alzheimer's dementia. And then mental health problems like PTSD, depression, anxiety. It's not only to the survivor of the COVID-19 patient, but it's also the family of the COVID-19 patient. So we have established ICU survivor clinics, which are following up these patients, the COVID-19 patients, in our clinic, and we're trying to provide physical therapy, behavioral therapy, and psychological follow-up. And we think that also has an impact on the long-term outcome. So in general, I just wanted to have these last couple of slides for the ICU organization and protocol development, because the intensivist is more than a bedside clinician. She is actually a leader in protocol development and protocol implementation. And in a pandemic situation, this is not going to be our last pandemic. This is not the first pandemic. Maybe it's our generation's pandemic, but we should be prepared, because the intensivist has to lead by example in the ICU for the nursing staff, for the medical students, for the respiratory therapists. Must be the leader in morale boosting and wellness maneuvers, because when it's a surge of COVID-19 in the community, the healthcare workers, especially the frontline in the ICU, are going to be your colleagues, are going to be your patients in that unit, in the same unit that you work. It is inevitable. The other thing is the intensivist should collect data, analyze it, and publish it. Publish it not for to make a name or a COVID-19 expert or fame, but publish it because we don't know much about this disease and we keep learning more. And the reason we keep learning more is that bedside clinicians are finding more and publishing it and disseminating the information. So robust research analysis and using valid data tools, we have to do that. The coordination of care, consult other services like the nephrologist, like Dr. Fazal was saying, the pharmacist, follow the epidemiological trends, look at the surge in your community, look at what the numbers are in your neighborhood, in your area that you're providing coverage in your hospital. If your community numbers are going up, be prepared in the ICU. You're going to start to get patients. So coordinate with the government agencies, hospital leadership, and be prepared. Be prepared by developing protocols. This is an example. This is our IU Health protocol page. It's the same thing that I went over again, but it's protocolized because you would never know who the person is who's taking care of the patient. It could be the doctor who created this protocol, could be actually the patient. So we have the convalescent plasma, dexamethasone, remdesivir. Everything is like, if they're eligible for these experimental studies, please contact study coordinators. This may not be applicable to most hospitals, but this is again an example of a protocol which even tells you what labs to get every day and how to check interleukin-6 level. Make sure you don't miss doing a simple test like pregnancy test on patients. This is remdesivir criteria, and this is convalescent plasma criteria. This is steroid use criteria, tocilizumab criteria. These are all published online in our hospital or available on clipboards in the ICU so that anybody can look at it and decide, okay, this patient meets this, check this criteria, and this is how we're going to give them convalescent plasma or remdesivir. So mindfulness exercises. We do, this is an actual picture from our ICU where we have a person coming in and doing exercises for the staff there, trying to motivate them, trying to boost the morale. These are coping resources for COVID-19 stress for your colleagues that work with you. Please don't think this is minor. This is actually a very, very important component of being an ICU doctor. I will take your questions and comments and before making some final remarks. This has been an excellent opportunity. Thank you very much for having me here. This is our 300th recovered COVID-19 patient that we discharged. It was in the local news, and the whole hospital staff is celebrating his discharge from the hospital. Thank you.
That's amazing, sir. Thank you so much for such an informative session. With your permission, we would like to ask some questions from the participants.
Sure, of course.
Our first question is, I am a healthcare worker and I was COVID positive. Now I have developed difficulty recalling names and other things. Could the memory loss be due to COVID? Is it a permanent damage, and is there any treatment for this? So
it is, yes, it is related to COVID. It is because of the delirium associated with COVID. We have seen 70 to 75% of patients have delirium, and one of the most important components of the post-ICU syndrome is memory and inattention problems. So yes, it is either directly or indirectly related to COVID-19, and yes, it is temporary. It is the fact that you can actually write about it and tell us about it means that it's not at the stage, or it's not that severe that it will cause long-term permanent damage. However, it requires access to resources, and everybody has different accesses. You know, a person in Pakistan has different access to resources than a person in America, or and Pakistan may be far better than some other country in sub-Saharan Africa. So everybody has different access to resources, but the resources that are available to you in Pakistan are online. Go to the post-ICU syndrome resources available through the CDC websites, to the NIH websites. Actually, even in our institution, the Indiana University Health website, you can go through that and go to the ICU survivorship clinic, and there's so much material on how to improve this cognitive dysfunction. there are exercises, from doing math problems and Sudoku to crosswords to playing video games which require you to recall things. There's so much available in terms of helping with this. Yes.
Thank you, sir. Our second question is, what is the treatment of acute disseminated encephalitis with COVID infection?
I'm sorry, can you repeat that question again?
Yes, of course. What is the treatment of acute disseminated encephalitis with COVID infection?
Yes, so again, there's no established treatment. We know that if it's associated with COVID-19, we have to treat the COVID-19 with all the therapies that we have available at this time, antiviral agents, steroids. But when you have acute disseminated encephalomyelitis or encephalitis, the some of the strategies that may help, which help non-COVID patients, is doing immune globulin, IVIG, or plasma exchange. And since there's very little data on if it works, if the patient is severely ill, we will use them. We will do IVIG and plasma exchange.
Okay, sir, thank you so much. Another question is, how can we differentiate between COVID encephalopathy, steroid-induced psychosis, and COVID isolation-induced psychosis?
If there is, in an acute phase, especially in the ICU patient, it's very difficult to differentiate. There's obviously a time correlation. For example, a patient was sick with COVID and had severe hypoxemia, was on the ventilator or not on the ventilator, but their mental faculties were intact. They were able to follow commands or on the ventilator, or they were talking to you and discussing stuff. However, once you started them on high-dose dexamethasone, time showed that they became have symptoms of psychosis. Then it's very clear that it's steroid-induced, and you need to taper down the dose of the steroids. However, in most circumstances, not clear-cut. Most patients have a combination of delirium and psychosis from a combination of these things. And the focus should not be trying to figure out which did that, but how to counteract it using antipsychotics at a correct time, such as quetiapine, or using dexmedetomidine for sedation rather than benzos, or trying to use haloperidol instead of lorazepam. So the management becomes more important than trying to find out the pathophysiology and the mechanism.
Okay, sir. Thank you so much. Another question is, why is azithromycin given in COVID-19 patients? What is the mechanism of action of this drug in these patients?
So COVID-19, and when it first came out, there was anecdotal reports from China about using macrolide antibiotics because there's data from, so some of the data is from strep pneumonia. In strep pneumonia, bacterial pneumonia, if you use ceftriaxone or third generation cephalosporins plus azithromycin, the reason it was used is to cover atypical organisms. But the mortality was way better than using ceftriaxone alone, even if there were no atypical organisms. So it's suggested that the macrolides have an anti-inflammatory component to them, especially azithromycin. And the same data has been seen in use of azithromycin in other pneumonia, such as Mycobacterium avium pneumonia and things like that. So the extrapolation of data, because we didn't have any armament to fight this when it first came out, the Chinese and the Italian and the Iranian experience is the first experiences in December and January. And so they used whatever strategy that was available, hydroxychloroquine, azithromycin, and azithromycin was used because of this potential immunomodulator effect at the alveolar epithelial level that we hypothesized. However, that has not shown to be actually working. There's studies large trials have shown that placebo versus azithromycin have no effect on severe COVID-19. Right now, we use azithromycin in those COVID-19 patients that we think have concomitant bacterial or other pneumonias. We've had 2 patients that have had concomitant Legionella pneumonia. So if we had not used azithromycin in the beginning, we would not have covered the Legionella. But the risk, we wanted to cover for broad spectrum because they had low bar consolidation in addition to ground glass opacities, and we were suspicious about pneumonia.
Okay, sir. Another question is, has hyponatremia been documented in COVID patients, and how should we treat it in COVID patients?
Hyponatremia is not specifically prevalent in COVID-19. Hyponatremia is a marker of severity of illness in severe pneumonia. The pneumonia severity index that was established in the early 2000s has hyponatremia as one of the major markers of severity of illness. So the lower the sodium level, higher it correlates with the severity of pneumonia. So for that reason, we monitor sodium very carefully. The reason for hyponatremia in most pneumonia patients is because of SIADH. It is not related to volume overload unless they have heart failure or kidney failure along with it. It's kind of an SIADH phenomena. And so there is no specific therapy other than fluid restriction if possible, and try to maintain sodium levels in a range of normal range, 135 to 145, by either giving saline or diuresing, and depending on the clinical situation of the patient. But it's not specific to COVID-19.
Okay, sir. Thank you so much. Another question is there any benefit of prophylactic antiplatelets or anticoagulants for the general public? And can they be administered in patients presenting COVID symptoms to prevent any thromboembolic phenomena?
That's a good question. I mean, we've all thought about it. Like, if there's COVID in our community, should we just start taking aspirin? Or, you know, the data is not there. I mean, I can just tell you that aspirin should be used in patients who have high risk cardiovascular risk factors in general and meet the criteria for taking aspirin, but not for COVID-19 itself. There is no good data that suggests that we should start anticoagulating people just because we have suspecting they have COVID infection, even if they're not hospitalized. So that's the first part of the question. Secondly, when they're admitted to the ICU, like I said in my talk, not everybody is a candidate for full anticoagulation. We look at the D-dimer levels, clinical context, and then decide on anticoagulation. Anticoagulation is not without risks. Major bleeding has been reported in a lot of patients in anticoagulation, and so you have to be careful. And again, there's, as I said before, this is a new disease. We're in this only for a few months. There's more data that needs to come out, that is coming out, and we'll have more information. Maybe the next time I speak here, or if I have the opportunity, it'll be a different data on anticoagulation.
Yes, sir. Yes, sir. Thank you. Another question is, how do we manage delirium in an elderly patient who's also hypoxic?
It's a really good question. It's one of the most difficult things to do. It includes two different, and it's very detailed, so I'm going to summarize it. You have non-pharmacological therapies and you have pharmacological therapies. So non-pharmacological therapies is reorientation, adequate lighting in the room, the adequate awareness of the day-night cycle for the elderly patient, including the diurnal rhythm, having a sleep cycle restored. And then the pharmacological therapies go along with that. We tend to use in our elderly patients to have them sleep through the night. Despite being sick, we don't do any lab draws or IV stuff during the night. We let them sleep from, say, 9 p.m. to like 6 a.m. We make sure they get melatonin or some sedating agent like trazodone at a time like 6 p.m. or 7 p.m. so that they go to sleep, and then they wake up in the morning. And when they wake up in the morning, there's the window, if there's a window in the ICU room, is open to see the sunlight. Or if there's a clock over there, it clearly shows that it's 7 a.m., not just 7 o'clock, so that they know that it's day or night. Continuous reinforcement by the family members, reorienting them, talking about kids and grandkids and things like that. But pharmacological therapy in severe delirium, you have the opportunity to give agents, short-acting agents like haloperidol, longer-acting agents like geodon or zisperidone, and try to avoid benzodiazepines in the elderly, because it can combat the acute psychosis, but it makes the delirium actually worse.
Okay, sir. Thank you so much. We have another question. We actually have a lot of questions from participants. The question is, We know about dislodgement of foreign bodies or gastric contents in various areas or lobes in supine and supine left or right positions. This participant wants to know about the site of dislodgement in prone position and the preventive pre- and post-op measures.
It's a great question. Um, when people are supine or in 45 degrees or say 30 degrees in the ICU, like laying flat, and they aspirate something in the lungs, it usually goes down the right mainstem bronchus, and it follows, it causes maybe the right middle lobe bronchus intermedius, or right middle lobe, right lower lobe occlusion. Uh, in the prone patient, the personal experience that we've had is that most of this mucus plugging, which I assume they're talking about mucus plugging, is mostly in the major airways, either in the right mainstem or the left mainstem, or even in the trachea. The most common is actually the trachea itself, because of being prone. There is mucociliary secretion against towards gravity, so everything is coming out. So even if there's a mucus plugging that went down, it tends to move up, and most of the airway obstruction that we have seen is in the upper airways at the trachea level, or the carina level, or in the right and left mainstem bronchi.
Okay, sir, thank you. Another question is, what is the flow rate of high flow nasal cannula?
The highest, the device that is 70 liters per minute. The ones that are most commonly used are 40 to 60 liters per minute. You can dial it from anywhere from 15 liters to 60 liters, depending on the clinical situation.
Okay, sir. Sir, is vitamin D deficiency linked with COVID?
That's a good question. There's a lot of anecdotal use of vitamin D. We do not use it routinely in our protocols. We start patients on tube feeding early on, and the tube feeding formula through the usually have the vitamin D supplements in it. The studies out there indicate that vitamin D deficiencies may contribute to long-term ICU acquired weakness, and but we have not given them separately as an agent in our patients.
Okay, sir. Is hydroxychloroquine safe to use in patients?
That's a good question. We could in the studies that have come out, the most recent one, which is on a preprint stage right now, from July, like 15th or something like that. It shows that it has no benefit in treating severe COVID-19, and increases the risk of arrhythmias, especially prolonged QT and ventricular arrhythmias. So it may not be entirely safe in all patients. In patients who have concomitant heart failure, heart disease, are receiving other agents, such as the delirium patient receiving, say, quetiapine or Geodon or any of these agents, haloperidol, it may actually make it worse.
Okay, sir. Another question is, convalescent plasma therapy is being used as a last-ditch effort in Pakistan. Is there any data to suggest that helps later on in the disease?
There is not good data. The plasma therapy is, there is a lot of theoretical benefits. It was used in the 1918 pandemic, the influenza pandemic in the 1919, because they had nothing else at that time. Even antibiotics were not invented at that time. So where the first case report was on 5 patients in China that got convalescent plasma, and they range from anywhere from day 10 to day 45 or whatever. The timing is the major concern. I don't know if it should be used as a last ditch effort, or should be used as part of the initial therapy, like steroids and remdesivir. And like I said, the bigger trials that are going on are going to look at that. The current data shows that in very severely ill patients that are on the ventilator, it's already too late to give it. It doesn't help. So it may not be last ditch. But in patients who are sick on high flow and getting sicker, it may be beneficial. So the timing matters a lot.
Okay, sir. Another participant wanted to know about code blue. Have they put a cap on how long they do it for? Usually it depends on the...
Can you repeat it, please?
Yes, of course. Another participant wanted to know about code blue CPR. She wants to know whether we have put a cap on how long we do it for, because usually it depends on the patient's response or the caregiver getting tired. But in this case, in case of COVID, do we have a cap on it?
We are trying to use the 30-minute mark as the mark at which we stop CPR. This data is from non-COVID patients. After 30 minutes of CPR, the risk of anoxic brain injury is unacceptably high. Greater than 60 minutes has shown very poor correlation with long-term survival. In COVID-19 patients, we also have to take into the clinical context of the code. If the code blue happened because somebody's airway was obstructed from a mucus plug, or they got a prolonged QTC from hydroxychloroquine or azithromycin or from an anti-delirium agent and got into ventricular arrhythmia, it is different than someone who has been so sick, who's on multiple vasopressors, who's been on 100% oxygen and 15 of PEEP, and all their organs are shutting down, and then the final thing that happens is a cardiac arrest. That patient is different from the other categories. So for that patient, it may not be suitable to do prolonged CPR because the cardiac arrest was the final step in their multi-organ failure. And in the aforementioned ones, it may be beneficial to do the CPR for more than 30 minutes. For example, if it's a 25-year-old who had CPR, who just has ventricular arrhythmias from a hydroxychloroquine. So it really depends on the context, but 30 minutes is usually the number that we are using in our protocols.
Okay, sir. One more question. Does vitamin C have anything to do with recovery time of a COVID patient?
Very good question. It's a very little data. The vitamin C data from 2018, 2019 made news for septic shock treatment because of its immune modulator effect, because of its effect on endothelial function, especially the hypercoagulable state. The data in COVID is lacking. A lot of hospital systems are using in their protocols, and they are saying that they're seeing a good improvement. But my recommendation is, if you are seeing good improvement with it, write it and publish it, analyze it, look at the data, and send it to a medical journal.
Okay. Sir, another
question, but
Dr. Maham?
I can't hear Maham.
So same as vitamin C, people are saying the same things about zinc, how it's also immunomodulating at times. So is that true? I mean, is there any data?
Exact same thing. If there is data, it has to be more than what people are saying. It has to be written and published, because unfortunately this pandemic has come in the middle of an infodemic, a WhatsApp-demic. So there's so much information out there, and we should stick to the verified, published data in the medical literature. Zinc data so far shows that it can improve the ICU-acquired weakness and critical illness polyneuropathy that is part of COVID. So yes, there may be benefit to using it, but is it the antidote against COVID-19? I don't think that there's data enough to support that. We use zinc in our tube feedings. It's part of the zinc is in the nutritional supplementation, but we don't specifically give zinc to our patients.
So Marvis seems to be having some connectivity issues. I'll ask the next question. Is indoor exercise helpful in COVID-19 stable patients?
I'm sorry, I didn't get it.
Is indoor exercise helpful in COVID-19 stable patients isolating at home?
Yes. Physical therapy of any sort, building your stamina up, improving your pulmonary reserve is very, very essential. It's essential. We found out from this pandemic that taking care of your body is actually of paramount importance. So with obesity and coexisting medical conditions, if you actually have a hypothetical scenario where nobody had any coexisting conditions or obesity or diabetes, and there was a spread of COVID-19 in that community, and everybody was like normal, healthy, normal weight with no comorbidities, how many would die? The numbers are astoundingly low, actually, if you calculate that. So yes, if you get diagnosed with COVID-19, doesn't mean that you just you do as much as you can. I mean, obviously, you don't want to worsen your hypoxia, but as much as you can, and exercise only builds up your strength and builds up your respiratory muscles. It will not tax you more.
So I think that's it for now. That's our questions have ended.
Thank you very much.
So thank you so much. You said that you might want to continue with the presentation. So do you want to do that?
Well, I just wanted to make a remark, and his remark was to thank you all, and especially Dr. Sabah Akhtar for inviting me and doing this. It's a great effort, and I really appreciate it. I also wanted to mention a very small anecdote, which is that in June of 1995, there was an incident on a British Airways flight where a guy developed tension pneumothorax. They had a rib injury before they got on the flight, and during the flight they developed shortness of breath, and there was an orthopedic surgeon on the flight who made an incision on the chest with a kitchen knife, used drinking alcohol to wipe the chest, and put in a tubing from some person's luggage and connected it to an empty water bottle to relieve the tension pneumothorax, and the patient survived. This happened in June 1995, on June 4th, actually. And on June 5th, I was a medical student working with General Mahmoud Akhtar, Sabah's father, who said, hey, did you all hear this story? And we had not, because we were studying and not watching the news, and there was only one news channel in those days. So, and he told us the story, and he said, you have to become the kind of doctor. How does this happen? How does pneumothorax happen on the plane? And almost all of us knew the pathophysiology of cabin pressure and descent and how the pneumothorax happened in that patient. And he said, what would you have done? And we were all like dumbfounded, because we did not know what that surgeon had done. And Dr. General Mahmoud Akhtar said that you have to become the kind of doctor who not only knows the pathophysiology and the mechanism of disease, but knows what to do with the patient right then and right at that time. Otherwise, it won't work out. And that was when the seeds for critical care were planted in me. And just I wanted to point it out because he's the patron-in-chief for this effort. Thank you very much.
Thank you for that, sir. This concludes our session.
I just also received news that one of my friends and class fellows just passed away from COVID-19. He was on the ventilator. Our class fellow, he's our course mate, Dr. Sabah Akhtar, and my course mate, and wanted to have condolences for him and his family. And again, to emphasize, in our communities, if we are seeing these patients, it's a good chance that we're going to be ending up on the other side of the equation. So we should probably have a small moment of silence for Dr. Kashif Nisar, who just passed away.
Yes, sir.
Thank you. May he rest in peace, and may his family have the strength to bear this loss.
All right, sir. Thank you so much for this.
Thanks.
It was an amazing session. I would like to thank Dr. Samina, who left earlier as well. Thank you for giving us your valuable time and your valuable information, and for joining us from so far away to share your experiences. Thank you to the participants for joining us. We hope that you gained as much as we have through this session. I know that personally this was my favorite session. I sat in a queue so far. So please do not forget to fill the feedback forms, as certificates will be distributed based on that. Thank you, Mavish, and thank you to our team in the background for supporting us. Ms. Dani, Dr. Sahib, Dr. Muhammad, Dr. Sabah, and all the others. And as Eid is approaching, I would want to wish Eid Mubarak to everybody. Please, Eid Mubarak, stay safe, and please enjoy with your loved ones. Thank you.
Thank you so much, Dr. Maham. It was wonderful hosting with you. Thank you to our speakers, Dr. Samina Fazal and Dr. Omar Rahman, for sharing such beneficial information and taking time out to increase our knowledge. Due to some connectivity issues before, I wasn't able to give a deserving introduction to our esteemed guest, Dr. Omar Rahman, and I would like to do that now. Dr. Omar graduated from Army Medical College. He did his internal medicine residency at Texas Tech University and critical care fellowship at Mount Sinai Medical Center in New York, where he was awarded Fellow of the Year. He served as an associate program director for a critical care fellowship in Pennsylvania and now is faculty at Indiana University in USA. He has won many teaching awards, has presented at international conferences, and has several publications to his name. Recently, he even had a COVID-related research published and is currently leading 3 other research projects on COVID while working full-time in the COVID ICU. Dr. Samina Fazal is also a graduate of Fatma Jinnah Medical College, Lahore, and she is a clinical nephrologist and has over 32 years of experience in the field of medicine. She is currently working at Baylor University Medical Center in Dallas, USA. Thank you so much, Dr. Omar and Dr. Samina, for joining us all the way from the States. It was really an honor for us. Thank you so much to all the participants for tuning in. We hope to see you on our 4th session for the COVEB series for mental health and psychiatry on Saturday, 8th of August, in which we will be hosting our first speaker, Professor Brigadier Muwaddad Hussain Rana, who has been honored Sitare Imtiaz and will be presenting on building resilience during COVID. Our second speaker is Professor Rizwan Taj, who will be discussing the psychological well-being of health professionals during these tough times. He is the head of psychiatry at PIMS, the principal of Federal Medical College, and the Dean of Medicine and Allied. Thank you so much, Professor Samia, for all of your efforts. She's our patron as well as our advisor for the academic team, and these series would not have been possible without her. Thank you so much, Dr. Sabah Akhtar, who is a co-founder of VFP and also the advisor for the academic team. She has been the backbone of this academic team, and this again would not have been possible without her. Thank you so much, Mr. Iftikhar Izdani, who is the CEO of Rahe Kamar and a partner of VFP. His company provides voluntary IT services for this noble cause. Thank you so much, Dr. Abil Tarek, co-founder of VFP, Mr. Zohaib Ansar, Dr. Muhammad Ali Bhatt, Dr. Meher, Dr. Tuba, and many others for supporting us on screen and off screen throughout this session. Please have a safe Eid, as we have already heard that Dr. Ashraf Nassar passed away, same as Aptabad due to COVID, and like everyone to pray for the departed soul, his family and friends. Thank you once again on behalf of Team VFP, Team Yardim, and Team RME. Allah Hafiz.
Allah Hafiz.